Giovanni.
Giovanni,
Start learning a hand language. Giovanni, you are muted. Muted.
I am muted.
Now you are muted. Yeah.
Now I'm. You hear me?
Yes.
Okay. So hi to everybody. I'm ready.
Okay. All right.
Can I check my microphone? Do you hear me?
Yes.
Yes.
Okay.
Anybody want to check the start of his presentation or the audio? I think all of you, your voice is there.
Yes.
Okay. Very good. It is winter, so it's cold.
Now, you can come and visit me. It's 48 centigrade.
Yes. Okay. So hi to
It is,
everybody.
it is zero degree here.
Oh, right.
Can I check my microphone? Do you hear me?
There is an echo coming from Amanda. Anybody want to check the start of his presentation or the audio? I think all of you, your voice is there.
Yes.
There is an
Very
echo
good.
coming after several
So it's cold.
seconds. Now,
yes.
come and visit me. It's 48 centigrade. Yes.
So hi to everybody.
Vladimir, I have sent it to you.
Nothing arrived.
Sí, perdón.
It's too far, probably.
Vladimir, check your email. I have sent it to
It's
you.
here. It's okay. Great. Thank you, Ramesh.
No problem.
Henry, du bist überall.
Ja, ne? Überall. Könnt ihr mich gut hören? Hier gerade ein Hubschrauber vorbeigehämmert. Jetzt ist, glaube ich,
Na, ist gut. Yes.
ja?
Yes. What great pleasure to see you, Marco.
You are muted. We can't hear you.
My great pleasure. Do we have any French guy with us?
Yeah.
They are suffering. No, nobody here.
They are suffering.
No, they were excused today.
We are happy that this time Brazil, Argentina are not participating.
What do you say about Argentina, Marco?
Because we don't need to suffer.
Yes, we are suffering. Yes, of course.
Yes.
So I might go with some household information. Please, nobody should be offended. As I said, we are going to control the time very closely. And the moderator, they are the one responsible. We tried to put the clock, but our web was hacked. So no clock, but the moderator will control. If you use the 20 minutes in full, there won't be any question or discussion, unfortunately. If you use 15 minutes, we have 5 minutes for discussion and questions. We have contained this one to be within the panel and the moderator, because the response to this webinar, special webinar, was tremendous. And I became an persona non grata because I have rejected several and I have not invited everybody. So I feel sorry about it. And I apologize to them, because talking about Professor Sami and the people, they want to greet him, to talk to him, and it will need, I think, a couple of days of webinars, not the 2 days webinar. And this is an exception. This is, Vladimir agreed with me. This is the first time we do a recognition for somebody, the 2 days webinar dedicated. So please, again, accept my apology, and we have to do this this time. Okay, and I apologize to the people listening to us that we are not going to take any comment from outside, but the chat is open. They can put their question, they can put their greeting, they can put their speeches, they can put their comments on this, and we'll try to pass it to Professor Sami to answer them at his ease and convenience. I'm seeing Ricardo is with us. He just joined us. Ricardo, you are muted. If you want to unmute yourself and greet the people with you. And the
Yes.
same with Miguel. Hi, Miguel. You are muted if you want to unmute yourself.
Yes. Hi, my
Hi.
friend.
Miguel,
Everybody, thank you very much for the invitation. It's a pleasure to be with you today.
Thank you.
Ricardo, all the best.
So can I share one slide, because I think, are we on time to start, or we still have few minutes?
Can you check it, Matt? Do you mind to share the screen just to check if it's working?
Do you see that slide of the meeting?
No.
No.
Not yet.
Can't see it, Matt.
You seeing?
Not yet. Not yet.
Not yet.
Not yet.
Never mind. Let's go back to. So I will unshare how I do. I'm trying to unshare my screen.
Does anyone mind to check it from your side? Any of you? To share your screen?
Pablo, I will.
Okay.
Can you see my screen?
Yes, perfect.
Yes, yes.
Perfect,
You can.
perfect. Perfect.
Miguel's
Thank
screen.
It was only the announcement of the meeting, no problem.
Thank you, Miguel Angel.
I think we have a full board. Everybody is there, and I'm seeing Dr. Kamlishi is joining us. Hi, good to see you. You are. You can unmute yourself if you want to give a voice for the and salute the people. All right. Abdusalam, you are muted.
Yeah.
And the same with Matthias. Hi, Matthias.
Is it
I
okay
will.
now?
Yes, we hear you.
Yes.
Hi,
I will-
hi everybody.
I will share my screen, Matt.
Okay,
Aman.
sure.
That side, can you see that? It's the program. Okay? Good.
Yeah.
Yeah. Okay.
Pablo,
And,
I have
Vladimir.
also
I'm seeing Moody with
I
us.
have the
Vladimir.
Hi, Moody.
Muted.
Ayman,
Hi, Victor.
I want to tell you that we are organizing a Congress in Acapulco on November,
Okay.
3 to 6 November this year. We think that COVID is going down, so we are very sure that we can make that Congress in Acapulco. This is a beautiful beach around the world. It is, I think, one of the best beaches. So I hope you to come to join us in that Congress. It's organized by College of National Neurosurgery here in Mexico.
What time, Victor?
On November 3 to 6. November.
So all the people on the screen, you are invited to that meeting. So we have to have a group trip to that place. And perhaps IP and myself will do the jump from the cliff.
20 meters.
It's not advised.
I'm sure Vlad will join us too.
30
We should
meters
jump
high.
together, I.
30 meters high.
Yeah. Vladimir will be waiting for us downstairs to check our eyes.
Yes. Should I survive?
Okay, I think we are almost there. We will start the webinar. I'll make a brief introduction. On behalf of the World Federation Neuroanatomy Committee, my colleague and my chair of the committee, Professor Benish, we are pleased to dedicate this special educational webinar to the legendary mentor and colleague and friends, Professor Majid Sami, for his lifetime achievement and worldwide devotion to teaching and education. I have to apologize to many friends, as I said, because I rejected few requests. Unfortunately, we cut the air transmission to them so they can put anything on chat for any question. We kept it locally within the panels and the moderators. Professor Majid Sami's journey goes beyond the Silk Road, as one said, and he launched several initiatives to establish great organizations, practice guidelines, and educational projects in the realm of neurosciences, and has received a plethora of distinct honors, recognition, and awards. Ours is only nominal. He is recognized as the Da Vinci of the modern contemporary neuroscience practice. He welds art with science, simplicity with efficient practice, innovation with critical judgment. He possessed the gentle, charismatic touch of his patient's heart and mind. Professor Sami's respect and credit neurological ancestors and respect his contemporaries and promote young generation of young neurosurgeons and his own implanted seeds and fruits around the world. And I trust the 2 days session will reflect this by his previous fellows or his close friends and collaborators. I leave the venue for Professor Vladimir Benish. He is the chair of this committee, and he is going to chair the session and will be the moderator. So we have a list of names. You didn't receive the list, Vladimir, aren't you?
I did.
Okay, so you will go over the list and introduce all the speakers to save time, and then we can proceed with the time to presentation.
Okay.
Vladimir.
Thank you, Imad. I will be as short as possible since we have 11 lectures and we need the time. So we shall start with Professor Komura from Japan, who will talk on cerebellopontine angel. Then we are going to Francesco Tomasello, whom we all know very well and who is a good friend of us and a member of the committee. He will follow with retromastoid approach for microsurgery of CPA lesions. Then our friend Marcos Tatajiba will talk on schwannomas. Why did you choose 7 schwannomas, Marcos? Is it the same as Lawton has 7 aneurysms and 7 AVMs?
Surprise, you are gonna see.
Yeah, okay. The next will be Amir Sami, the son of Majid, from INE, who will talk on neuroanatomy for neurobionic hearing restoration. Henry Schroeder, a man from Greifswald. Henry, hello.
Hi.
Henry will give a lecture on endoscopic assisted resection of vestibular schwannomas, and I'm looking forward to see the usual excellent images and videos by Henry. I then will go a little beyond neurosurgery, which is a pity in my mind. I'm going to talk on carotid endarterectomy, which in my mind is neurosurgical procedure, and I hope to convince you. Abdul Salam Kamlichi will talk on CNS infection, which hopefully will be interesting to us all. Another very good friend and one of the best friends I have, Miguel Arraez, is going to talk on surgery in and around Meckel's cave, which is really an exciting territory, and I believe that Miguel will do a perfect job as always. Ricardo Ramina will talk on surgical anatomy of the jugular foramen, which is one of the most difficult regions in the skull. Enrique Osorio from Colombia, I don't see him here with us, but he definitely will join in time because he is too much to the west to rise that early up. He will talk on microvascular.
Enrique
He's with us.
He is he? Hello,
Yeah.
Enrique, I don't see you. Oh, I see you now. Hello. microvascular compression in trigeminal neuralgia, result and tips. So let's look forward to the tips for MVDs. And today's session will be closed by Giovanni Brogi from Italy, pioneer humor surgery tips and tricks. So one of the most exciting regions, at least in my mind, will be the last today. Ipe, can I ask you to check the time, please?
Yes, I'll do just that, Vlad. So every
Okay.
20 minutes, I'm going to tell you that it's time, and I'll tell the presenter. So that'll be my duty for today.
Thank you, Ipe. Very good. So let's start, and let's not waste any more time. Let's start with Eiji Komura from Japan, from Kobe University. Professor Komura is a senior consultant neurosurgeon, and his main interest is in skull-base surgery. Eiji, please.
Thank you, Professor Benes. It is my great honor to start with my presentation. I will share my screen. Can you see it?
Yes, we can.
Okay, then start. Today, I am going to talk about basics of cerebral ponti angle surgery, especially focusing on anatomy for young neurosurgeons. It might be boring for advanced surgeons. First, let me introduce myself. I worked in Neustadt from 1984
Eiji, could you please
to
talk a little
87.
louder?
I learned a lot from Professor Sami. I returned to Japan and from 2002 to 20, I served as the chairman of the department at Kobe University Hospital. I hosted the first massive meeting in 2013. Many friends came to Kobe. Last year, I retired from Kobe University, and now I'm working at Kinki Central Hospital as a hospital president. Now, this MRI shows left CP angle. You see here an anatomical illustration, facial nerve, cochlear nerve, and vestibular nerves. At fundus, you find here superior and inferior vestibular nerve, transverse crest, and singular nerve. In the lateral sigmoid approach, we are coming from this direction. This picture shows right side internal auditory canal where the posterior wall is drilled away. You see the nerve structures. Vestibular nerves are on the front, facial and cochlear nerve are on the back of vestibular nerves. This is transverse crest. This illustration shows right side fundus seen from the medial side in the sitting position. Facial nerve is at the superior anterior corner. Cochlear nerve is at the inferior anterior corner. At the fundus, transverse crest horizontally separates superior and inferior compartment. When we approach via lateral sigmoid root, vestibular nerves cover facial and cochlear nerves. I know great advantage of same sitting position. However, in Japan, we usually use park bench position due to problem of anesthesiology. In the park bench or lateral position, the right side internal auditory canal looks like this figure. Transverse crest runs now vertically instead of running horizontally. We may call it vertical crest. This is the illustration of the right side internal aortic canal, and this is the left side. Vestibular nerves are on the front, facial and cochlear nerves are on the back of vestibular nerves. This is a very interesting picture of left vestibular schwannoma during surgery. This tumor is a medial type, and there is a space between the tumor and the fundus. You can see superior and inferior vestibular nerves in the foreground, and facial and cochlear nerves in the back. Inferior vestibular nerve continue to the tumor in this case, so that this is the tumor origin. Posterior wall of internal aortic canal should be opened widely, both cranial and caudal direction. In case of hearing preservation, do not enter the vestibulum. If we do not destroy the vestibulum in order to preserve hearing, we cannot see the fundus. Endoscope will help you to check the fundus if necessary. From the internal aortic canal to brainstem, vestibular nerves and cochlear nerve are fused to form a vestibular cochlear nerve. At the fundus, facial nerve is at the anterior superior corner. It lies now anterior inferior to the vestibular cochlear nerve at the brainstem. Thus, nerve position rotates 90 degrees. Again, at the brainstem side, vestibular nerves and cochlear nerve are fused to form single vestibular cochlear nerve. The facial nerve locates anterior inferior to the vestibular cochlear nerve at brainstem. Key anatomical structures to find root, exit, or entry zone of 7 and 8 nerve are glossopharyngeal nerve, anterior inferior cerebral artery, flocus, and choroid plexus. This is the intraoperative photo during surgery of left hemifacial spasm. Flocus is retracted along glossopharyngeal nerve. Choroid plexus is identified. In this case, the offending artery, anterior inferior cerebral artery, is pulled up to decompress the facial nerve. Now, vestibular schwannoma. This is a small tumor, but where is facial nerve? At both ends, they are fixed. However, facial nerve location is variable on the tumor. Let us have some examples after large tumor removal. In this case, facial nerve is ventral with fanning. In this case, ventral location. In this next case, ventral but more cranial near trigeminal nerve. In this case, facial nerve is shifted cranially, crossing trigeminal nerve. This case, further cranial position just below the tentorium. As I shown, facial nerve location is variable on the tumor. Always we must debulk the tumor and identify nerves at both ends, where we can apply the knowledge of normal anatomy. Please try to remove only the tumor utilizing correct layer. Left side tumor with good healing. Tumor is exposed. Arachnoid membrane covering the tumor is peeled away. Mass reduction is started. After mass reduction, we are coming to the brainstem side. You see, gross pharyngeal nerve, anterior-inferior cerebral artery. I elevate the tumor, then you find the facial nerve. We start to separate the tumor from remaining nerve fibers of vestibular nerves. Try to preserve remaining fibers. Dissection is continued from inferior, from lateral, and from medial. Concept is to remove only the tumor. After removal, you see very thinly spread eighth nerve. Behind it, you see the facial nerve at brainstem. Hearing is preserved. Even in large tumors, some cases are easy to remove, others are difficult. Let us consider tumor-nerve interface. As you know, tumor is arising from a small part of eighth nerve. For these types, there are thick remaining vestibular fibers and peritoneum between the tumor and facial nerve. Dissection is not difficult in this case. White side small tumor. Tumor is covered by remaining nerve fibers. Situation is as like as this illustration. These fibers are separated. I remove only the tumor, and other than the tumor is remained. Next is an interesting case. In this case, tumor was grown exophytically on the eighth nerve. Tumor is separated from the eighth nerve. After removal, almost normal eighth nerve over the facial nerve. This is an exception. How about this situation? In this kind of tumor, tumor-facial nerve interface is very thin. This is a solid giant tumor. In this case, there was severe adhesion, and tumor-nerve interface is very thin. Sharp resection is necessary between the tumor and facial nerve. Fortunately, complete removal could be done in this case. Next case. In this case, adhesion was so severe, a tiny piece was left on the facial nerve as you see. This is near total removal. Normal facial function after surgery. This tiny remnant was followed and showed no change for the next 5 years. Near total removal is accepted for giant tumor or in case of severe adhesion to keep function. My surgical reference according to tumor size, good facial function was obtained in 94%. However, good facial function drops to about 70% in giant cases. As nerve location is variable on the tumor, always we must debulk the tumor and identify nerves at both ends, where we can apply the knowledge of normal anatomy. Remove only the tumor utilizing correct layer. Just 2 years ago, I invited Professor Sami to the Japanese skull-base meeting, where I was present. Despite he was in vacation, he kindly came to Japan and delivered a fantastic lecture. I always try to catch him up, but he goes faster than I. My task is further transmitting what I have learned, including his philosophy. Finally, I'd like to express my great thanks to Kanan for giving me a good opportunity today. Thank you for your attention.
Thank you.
Well, he's
In order to,
back. He's
Is
got
there
5
time?
minutes. He's
in
got
order
5
to
minutes more.
keep time, I recorded my presentation. So,
Okay. How much time do we have?
5 minutes more, Vlad.
5 minutes more. Okay, are there some questions or remarks from the panelists? It was a great images. Really perfect.
I think I can make a comment.
Keiki.
Hey, Komura, hi, nice to see you.
Hi, nice to see you.
Very, very nice and very simple lecture. You made it so simple that even a fresh undergraduate can start operating on acoustic tumor without sacrificing the facial. You made it look so simple. But an important point that you must mention is that do not coagulate. There's a time, and there are tumors you have mentioned about exophyting and normal intrinsic tumor, but there are some tumors which are very fibrous, which are very vascular. So there are different types of vestibular schwannomas which have different problems, anatomical problems. But a very important point which we have all learned from Prof. Sami is not to coagulate and to use a lot of irrigation. And sometimes you can have an anatomical function, anatomical preservation, but you may not have the facial function because you have coagulated some blood circulation. So that point needs to be mentioned.
Thank you, Keiki. Nice comment. I completely agree with you. At least coagulation is very important. But today, I would like to show the anatomy. You know,
Yes.
my point of talk is anatomy, normal anatomy, and pathological anatomy for young neurosurgeons, especially. For experts, my presentation will be very, very boring. You know, I know.
Thank you very much, Komura. I like very much your presentation. And I like to make a comment. We are seeing some patients, and we are published this case now, the origin of the tumor. If the tumor is originated between vestibular nerves and seminal and cochlear nerves, we classify it as tumor type A. And if the tumor is growing behind the vestibular nerve, not between the nerves, we classify it tumor type B. And that makes it much easier to remove than those tumors growing between the nerves. Have you seen this kind of tumors?
Yes, I think such kind of tumor maybe originate from the nervous intermediaries.
That's right.
Isn't it?
That's right.
Okay, gentlemen, we should go forward. Thank you, KJ. It was excellent, and thanks, Keiki and Ricardo, for comments. We now go to Professor Francesco Tomasello, who is the professor and chairman emeritus of Messina University. He also is an honorary president of WFNS, so this is a very appropriate place for him. And Francesco, I just recall our trip with Majid through Iran a few years ago. It was real fun and great. Should you have any pictures, send it to me because I have none, please. Okay, Francesco will talk on...
I am trying to share my screen with you.
Yes, do so, please. Francesco is going to talk on retromastoid approach for microsurgery of CPA lesions. So we are continuing in the topic very dear and important to Majid.
Can you see my screen there?
Not yet. Francisco, not yet.
Francesco?
I don't understand why. Because
on the bottom side, you have some buttons, and you'll have to go to the share screen option.
yes,
One.
yes, I'm pushing the button, but
Francesco, should it doesn't work, we probably should go to the next lecture and you will correct this, or do you want to try?
yeah, I was sure that it was working, but now I don't understand why.
You can exit and come back. You can exit and come back.
You will come back next, and probably Sanjeeva.
Yeah, yeah.
And
I
so
will speak
let's
up.
go to Marcos Tatajiba, who is a professor of neurosurgery and chairman in Tübingen University, and Marcos is one of the best known pupils of Majid Sami, so it's very appropriate for him to talk on schwannomas, and there are going to be 7 of them. Marcos, please.
Thank you very much, Vladimir. I'm really very honored and thankful for the invitation. I hope you can see my screen.
Yes.
Yes. Yes. You asked me why this title. You are going to see the answer during the presentation. First of all, I'd like to thank you and Imad to put together the tremendous people. This is a fantastic opportunity to honor our teacher, Professor Majid Sami, with whom I worked and learned for more than 16 years directly, and I'm still learning from him. Every time we meet, I have the opportunity to learn something more. But it was a very intensive time, 16 years in Hanover. I have no disclosures for this presentation. As you know, vestibuloschwannoma is one of the most common benign tumor within the head. And despite of that, there is no clear evidence which treatment is the best one for each patient. We have many options: observation, radiotherapy, radiosurgery, microsurgery, different approaches, and even chemotherapy in the special cases of neurofibromatosis type 2. Although these tumors are almost always the same histological type, and malignant tumors are very uncommon, they may present very, very differently. And depending on the presentation, we are going to have different strategies and different results. So far, we have done in Tübingen, since I've started my activities here, more than 1,600 tumors, and all of them operated on via the retrosigmoid approach. You are right, I was inspired by the beautiful work of my very good friend, Michael Lawton, and I have all of his books, and I thought, why not do the same with the schwannomas? So I started to study these tumors many years ago. I would like to share with you one interesting division. One is the intercanalicular tumor, and then, as Eiji Komura has mentioned, the medial vestibuloschwannoma, the common one we are used to treat, and the cystic one, the giant one, the double one, neurofibromatosis type 2, and the recurrent one, so previously treated via radiation or surgery. The technique we used to treat all of them is very similar, using the retrosigmoid approach in the large majority of the cases, using intra-op monitoring, trying to get the sensory and motor evoked potentials of the legs and arms, and also the potentials of the facial nerve, cochlear nerve, and the lower cranial nerve is the tumor if the tumor is too large. There is only one difference. If the tumor is small, we put the patient in supine position. If tumor is large, we operate in semi-sitting position, but always with the legs positioned over the level of the head to avoid air embolism. I try to go quickly through the different options because they are really different. Small vestibular schwannomas like these, usually they are observed. We know that these tumors grow very slowly, and we can observe many of these tumors for many years. We have more than 300 vestibular schwannomas under observation in our department. But careful observation is important. Why? Because we never know when a specific tumor will become bigger and will need treatment. In older patients, if tumor is growing, but it's still intercanalicular, one very good option is radiosurgery. In my opinion, this is the classical indication for radiosurgery, elderly patient with growing small vestibular schwannoma. But in young patients, treatment of choice is not radiation. Treatment of choice is surgery. Why? We have here a unique opportunity to cure the disease, and the functional results in those cases, they are very similar with the results of radiation. We have a very high rate of hearing preservation and functional facial preservation. So here a small example, small vestibular schwannoma. We do in supine position. We call Janetta position. It's similar for trigeminal neuralgia and hemifacial spasm. And then the first step is opening the interauditory canal, as we have learned by our teacher, Professor Sami, opening the canal, and then exposure of the tumor, and then dura is cut, tumor is debulked. Slowly, the fibers are dissected away from the tumor, preserving the facial and the cochlear nerve in those small tumors is in a number of cases feasible, and bimanual dissection of the tumor surface from the nerves, always under control of electrophysiological studies. And finally, when everything is finished, we enter with the endoscope to check whether tumor removal was complete or not. Here, the high jugular bulb in this case, we had to skeletonize in order to enter this area. And you see here the transverse crest, facial nerve, cochlear nerve preserved. And we can also, with endoscope, detect any opened air cell that can be closed directly under direct view in order to avoid CSF leak. So here is one of them. Sometimes we can't see these air cells under the microscope. Our technique is to put bone wax directly to close the cells, and then muscle and fibrin glue. So this is the final situation. In these cases, here is a long-term evaluation of 576 cases of vestibular schwannomas according to the facial function. Only 1% of the patient had palsy before surgery. After surgery, you see here small tumors. A number of patients deteriorate immediately, but they improve over the period of follow-up. And you see in T1 tumors, you have 100% of Haus-Bregman 1 and 2, and 99% of Haus-Bregman 1 and 2 in T2 tumors. So that's the reason. It's a very short summary. Observation as first step in these intercanalicular tumors in elderly patients. If the tumor is growing, radiosurgery. In young patients, surgery, because functional results are very similar to radiosurgery, and with a chance of complete cure of the disease. The medial vestibular schwannoma, the fact that the tumor is not growing too much inside makes the resection easier. Even in large tumors, we can achieve a complete resection and the excellent functional preservation in these patients. even in such a very challenging case like this, patient is clarinetist in a European Philharmonica, and we could remove the tumor totally with preservation of function. You can hear here. Maybe you know this music. Patient knew that I'm coming from Rio, so he brought this music to me afterwards. So our recommendation in these cases is observation as first step in small tumors, but in larger tumors, of tumor is growing, young patients, we can achieve really excellent results with surgery, radiosurgery, only in small growing tumors in elderly patients. Then we have the usual, the normal vestibular schwannoma, as this case here. This is a young patient with tumor growing into the interauditory canal and outside. So it's a T2 to T3 tumor. We open the canal carefully, and then tumor is removed from the canal. We can check with the endoscope whether everything is removed or not. If there is any tumor remnant, we can detect here some remnant tumor, then we can remove it via endoscope or microscope. It doesn't change. And then afterwards, tumor will be debulked and separated from the surrounding nerves. So facial nerve, cochlear nerve can be dissected away. And if patient has good hearing before surgery, there is a realistic chance of hearing preservation. We do a lot of irrigation, as also Keiki Turel has mentioned. We almost never use bipolar, only in very special circumstances. We use a lot of irrigation and irrigation with papaverine solution in order to keep the perfusion of the nerves without any impairments. And then the endoscope is showing opened air cells, which are closed directly on the endoscopic view. So this is the patient afterwards with her family and hearing preservation. In very young patients, we have sometimes special vascularized tumors with bone destruction, but also these cases can be well done. We do everything possible to remove the tumor completely in order to avoid recurrence afterwards, of course, giving the facial nerve priority. Sometimes, in order to achieve complete removal, we may have facial palsy, Haus-Breckmann 2, Haus-Breckmann 3, and even Haus-Breckmann 4. So such these cases here, you see Haus-Breckmann 4 in all of them immediately after surgery, but at long term, all of them recovered to Haus-Breckmann 1 or 2. So we should not be afraid if the patients may develop functional deficits. If facial nerve is well preserved and MEP is showing at least 50% function, this patient will recover. As our evaluation shows, you see T3 tumors immediately after surgery. We may have deterioration in half of the patients, but they recover. And here, Haus-Breckmann 1 and 2 in 93% of the patients. Cystic vestibular schwannomas. They are unpredictable. Cystic schwannomas may grow very fast. The growing is unpredictable. That's the reason we recommend early surgery in order to avoid a very fast growth because of the fluid collection. Radiosurgery doesn't work well in these cases, and we should try to avoid, or at least to force removal of this part of the capsule, because we may cause facial deficits in these patients. So more conservative approach is recommended, removing the solid part, and if it's too much attached here, to avoid that removal. So recommendation in these cases is to be more conservative in terms of capsule removal, but try to go early to surgery because the growth is unpredictable. The giant tumors may make a lot of trouble. That's the reason we prefer to operate these cases always in sitting position, irrigating a lot. We have done a study here in order to check whether the semi-sitting position would be of help in such a cases. And we checked 150 large tumors, large and giant tumors. And you see here, because of the irrigation and because of the clean field, surgery did very fast in these cases. And so we could avoid very long surgeries here. In general, we needed 4 hours from skin to skin to remove these tumors. You see here the results, facial deterioration at the beginning, but then later on, many of these patients improved. We could achieve in 77% of the cases Haus-Bregman 1 and 2, and in 91% Haus-Bregman 1 to 3. We do have these cases here, but we prefer, and the patients are more satisfied if the patient is young, to achieve complete removal and cure of the disease, and the patients will improve to Haus-Bregman 2 or Haus-Bregman 3, like in these cases here, or this young lady, for her extremely important to have a tumor control, like you have here, and with thin tumor remnant in order to preserve the facial net. And I'm almost finishing the lecture. In neurofibromatosis type 2 cases, situation is very different. You may have plenty of tumors in this more aggressive form, and in the less aggressive form, you may have only the bilateral tumors. Tumors can grow very fast. We must pay attention to that. There is this classical historical publication of Professor Sami showing that in neurofibromatosis type 2 cases, they are more difficult to remove. And sometimes we have to remove the supratentorial tumors first, and later on we can deal with the bilateral vestibular schwannomas that can be very large and be mixed with meningiomas. I'm not going to this video, just showing that sometimes we have to include subtotal removals, and we have seen that performing subtotal removals, in a number of cases, we are going to decelerate tumor growth. The remnant tumor growth grow usually slower than the primary one. And we can, in many cases, doing subtotal removals, preserve hearing over long term in these patients like this young lady. Bevacizumab can be used for these patients as well as a second strategy besides surgery. I'm not going into this graphic. Maybe this lecture will be recorded and you can follow this schema. And finally, the recurrent vestibular schwannoma may be very difficult to treat. We can have a recurrent tumor following surgery, following radiation, and following surgery plus radiation. Also, this publication here of Professor Sami for more than 10 years ago, showing that particularly the previously operated and radiated tumors, they can become very challenging and very difficult. Here, one case, we encountered a lot of difficulty to remove this tumor that had been irradiated and operated on before. So in these cases, please consider a second surgery in recurrence in young patients instead of going immediately to radiosurgery. In elderly patients, radiosurgery is very much indicated. For following radiosurgery, conservative surgery is recommended because of the risk of facial palsy. But if the patient is having recurrence following radiation and surgery, consider please total removal and nerve reconstruction as well. Not an easy decision, but sometimes recommendable. The goals are stabilization or cure the disease and preservation of quality of life. For these, we have we have to learn from the masters and trying to visit large centers in order to get more experience. Thank you very much for your attention. It was a very pleasure to participate.
Bang on time, Marcos. Bang on time. Very good.
Thanks, Marcos. It was excellent. Can we have some questions?
Yes, I have.
No, we don't have time for. We don't have. I mean, we have only 1 minute, so maybe one question perhaps.
So one very pointed question.
Yes. Yeah, we mentioned about irrigation is very essential, but I think the use of CUSA, we have to be with care to avoid to come to the near the capsule from inside, as it can cause a catastrophe, and to use a low power CUSA, especially if you are doing with the micro one. I prefer not to use it if I can leave a bulb to hold on and dissect it nicely with the irrigation. What is your take, Dr.
Yeah, you are completely right. I use 30% power when I use the CUSA. Yeah.
Okay, thank you, Marcos. It was great. Francesco, Professor Tomasello, are you ready to share the screen?
Vlad, I need more time. So
you need more time. All right, so let's go ahead. Amir, are you with us?
Yes, I am.
Very good. So we now have son of Professor Majid Sami Amir, who is Vice President and Deputy Director of INE in Hanover and in Beijing, China. He's the Residency Training Program Director in Lower Saxony, and he's also WFNS Financial Committee Chair. So lots of functions and lots of good surgeries on your hands. Amir, please go ahead.
Thank you. Can you hear me well?
Yes, sir.
Okay, great. So first of all, I'd like to thank Imad and Vladimir for putting up this wonderful program, this webinar. You have done so many of these.
We lost you, Amir. We don't hear you.
Amir's presentation is stuck.
Amir? Anyone in touch with Amir?
I can try to call him.
Yes, maybe, yes, you should, Henry.
Yeah, but he's still talking, you hear it.
Oh.
All right. Can we get in touch with Amir somehow? And meanwhile,
Henry is calling him. Henry is calling him, Vlad.
His mobile box.
We are calling Henry him.
He had it's his mobile box. It's not. You cannot talk to him. His handy is off.
I wonder whether he is still presenting.
He's still talking, apparently.
Is he? I don't see him. Imad, your recommendation? Unmute.
Hello, here is the.
No chance.
I think we should go on to the next speaker and then let Amir come back.
All right, the next on list is Professor Henry Schroeder from Greifswald. He's the professor and chairman in Greifswald University. Is it Ernst Moritz Arndt Universität?
Not anymore. University Medicine. We are now.
Okay.
He said the Ernst Moritz Arndt was not correct in his behavior.
I see.
Jewish problems, you know. That's why they kicked him off.
I see. So you will sometimes tell me confidentially what he did. And now we are going to listen to your lecture on endoscope-assisted removal of vestibular schwannoma. Henry, please.
Okay, thank you, Vlad, for this nice introduction. Thanks, Imad, again for inviting me. So my topic is endoscope-assisted resection of vestibular schwannomas. And I must say I have learned from Majid a lot how to deal with this disease. So my concept is endoscope-assisted microsurgery. We did this very early, and it was just a combination of microscope and endoscope. And initially, I got a lot of criticism from Majid when I presented it in Alexandria in Egypt. And now I'm very happy that he is also using the endoscope frequently. And the advantage is that you come in with the endoscope close to the lesion, you have this angled view, which is compared to the microscope. But you can also use a bimanual dissection, the same as under the microscope. That's why it's so useful. So it's not a competition between these two, but it's a collaboration. So we use very small endoscopes, 2.7 millimeters in diameter. So they fit easily in between the cranial nerve in the posterior cranial fossa, different angles of view. It's very important. And of course, you need angulated instruments when you want to dissect a lesion which you can only see with an angulated endoscope. That's why we have this curved curettes. And HD camera, I think it's a must today. What is the advantage of the endoscope? Marcus has already mentioned it. Even if we drill the posterior wall of the internal auditory canal, there's still a blind angle in the fundus, and there we use the endoscope. And you can see this is the fundus, transverse crest, you see facial nerve, you see the cochlear nerve, and you can also inspect the bony structures around the internal auditory canal to look for open air cells, which are easily be overlooked under the microscope because you have this tangential view to it. So the surgical technique is simple. We start with a microscope. So most of the surgery is done under the microscope. Then when I want to look around the corner, I take the 30-degree endoscope first. I have it freehand just for inspection. And then if we see tumor, which is still in the fundus, I fix the endoscope here with a mechanical holding arm, and I have both hands free for dissection. And then the screens are in front of you for ergonomic work. Of course, monitoring of facial and acoustic function is essential. We always map the dorsal surface of the tumor with the electrode to rule out that we have an untypical course of the facial nerve, which I have experienced in some cases. And the dissection is very important. It is a bimanual dissection with traction and counter traction. That, I think, is the most important technique. So what are indications for treatment? Marcus has already mentioned it. Not every tumor is growing. This is a small tumor in a young patient, and I advised to him to have it resected because he has a good hearing. The tumor is small, but he is a teacher of sports and he is doing exercises on the high bar. And he asked me, can I do that afterwards? And I said, I don't know exactly. And he refused surgery. Now I watch him for 10 years. Tumor is not growing much, and he has a very good hearing. So the course of the lesions is sometimes unpredictable. If I see this tumor which goes to the cochlear, then I know when I make the surgery, the likelihood of deafness is very high, and I will not bring the patient to surgery. Sometimes you see the tumor is in the cochlea already. Usually these patients are already deaf, then we just watch them and we do nothing. Only if this is growing, we would do surgery. Hearing is lost then already. So usually we use a retrosigmoid approach. We use simply a supine position. That is used for the smaller tumors, intracanalicular or also grade 2 tumors. The head is a little bit elevated. That the cerebellum can fall back by gravity, and then we rotate the whole table. So I have a very good view without the need to turn the head too much to avoid venous congestion. And then we do a middle retrosigmoid craniotomy, the size about 2 centimeters. It's very important that we see the dorsal aspect of the sigmoid sinus, that we go very close to avoid unnecessary retraction. Then what we have designed is a suction spatula together with Feeling Company. I like this very much because it gives us a third hand. So I bring it into the lowest point in my surgical field, and then I can irrigate, and I have always a drainage of the CSF. So it's the same like in a sitting position. All what I bring in comes out, and I can continue my surgery under continuous irrigation, which is very important. An example is a 66-year-old female with hearing loss. Not too much, it's not too bad. A little bit. So the right side is a tumor. It's not going to the fundus. For a surgical point of view, this is good. We have to drill a little bit of the dorsal wall of the internal auditory canal. And I can have irrigation. And you see my suction spatula is here at the bottom. The tumor is exposed. We usually make a 180-degree unroofing of the bony canal. And so I can have two instruments without the need to take a suction because I have a clean field because of the suction spatula. And that is most importantly what I have learned from Majid, always irrigation, because this shows you the nice plane. Only with irrigation you can find this plane very nicely. You have no clot formation, you have always a good view. So constant irrigation while dissecting the tumor is a bimanual technique with traction and counter traction. You see this, the nerves here, you grasp the arachnoid and you dissect it away from the tumor. So the nerve is basically not touched. And because of the suction spatula, I have this nice view. Then we use the endoscope to look for remnants in the fundus. And that's why I like this suction spatula very much. You see the amount of drilling we had and preserving of a very good hearing in this lady. So another case is a 28-year-old male. He had a hearing loss on the right ear. And then they made MR imaging and they found on the left side a small tumor in the fundus. And of course, you have to preserve this hearing because on the other side, he has another problem in the inner ear and cannot hear well. And he was advised to get radiosurgery. But if you look to the literature and you see papers with a long-term follow-up of 15 years, you see the hearing preservation rate is only 1/3. And also malignant transformation is rare but may occur. And so he decided he does not want to have radiation, but he wants to have an attempt of surgery. Of course, we said to him, if we have a deterioration of the acoustic evoked potentials, we will stop the surgery. So when you drill here, you have still a blind corner, and that is a time for the endoscope. So initially we start with a microscope. Of course, you see the vestibular nerves. The growth of the tumor was good because it was posterior to all the nerves. So we had not to dissect much of the vestibular nerves. We resect the medial part of the tumor under the view of the microscope. And then the part which is laterally is a blind dissection. So we switch now to a 30-degree endoscope and you see how nicely you may look into the canal and you see exactly the plane between the residual vestibular fibers and the tumor. And that's why you can dissect it very precisely, avoid damage to the nerves. And fortunately, the acoustic evoked potentials remain stable during the surgery and we had a gross total resection of the lesion. And you see very good hearing after surgery, no deterioration, and it's now 5 years after surgery. So I think that's a much better option than the radiation, as Marcos agreed on it. Another case is a 46-year-old female, hearing loss left ear, but still good hearing. You see the tumor goes to the fundus. So we look to the CT scan, you see we could drill at about 5 millimeters, but the posterior semicircular canal is very close. So it's a tumor, I opened, I drilled it, and then I look with the endoscope and I drill too much. You see, I open the vestibule and the posterior semicircular canal. What you should do then, I immediately put muscle on it and fix it with fibrin glue without any suction on the opened vestibule. And then I was lucky all the time, the potentials remained stable during surgery. After tumor resection, I fixed it with fibrin glue more. And you see here, I opened the vestibule and the posterior semicircular canal. So it was not good, wrong blood judgment, but I think if you are lucky and you do not suck off the endolymph, then you can get still a good result. You see, she remained with a solvable hearing on the left ear. So no suction on it, just put muscle and fix it. So what is the strategy in large schwannomas? In large schwannomas, I was taught that we have always to have a gross total resection and we had a supine position. But you see the tumor is here. I always need a suction. I have not a good clear field. I have to suck it and it's a bad visualization. And that's why I switched in a strategy completely in the large tumors. We now use a semi-sitting position, what I learned in Hanover. Of course, we have the echo for the heart Incision is a little bit large. The disadvantage is that you have always a little bit retraction, and the larger tumors you see, there's a little bit contusion, but clinically it's not a problem. There's a risk of air embolism, but this can be controlled. Cerebellar retraction is not too much, but pneumocephalus can happen. So I will never put a guy with a hydrocephalus in a sitting position, because this may happen. And I think everybody of you have the same experience. If the CSF pathways are wide, then this may happen and should be avoided. This was an 11-year-old girl. She presented with problems of balance and headache. You see on the right side, she has still a very good hearing, although the tumor is large. Sitting position, craniotomy is a little bit larger than in the supine position. Technique is the same. So we open the internal auditory canal widely. And then we look for the facial nerve on the surface with the electrostimulator. If not, then we open this tumor surface, the capsule, the vestibular fibers, take a histology, biopsy, and then vigorous use of the ultrasonic aspirator. And then after this, again, you see the advantage of a sitting position. And it is, for me, pretty clear these tumors should be done semi-sitting, because you see there's a lot of hemorrhage, but it's not disturbing me because I just irrigate and have always a good plane. This is a facial nerve identified in the internal auditory canal. This is a residual vestibular fiber with tumor on it. It's resected. And then here, this is a cochlear nerve. And because of this irrigation, no coagulation, just dissection by manually traction, counter traction, you have just to find the right plane. And then if you have this plane, you can easily dissect. The brainstem is coming here. But with this bimanual dissection and continuous irrigation, you always keep the plane. And then the question is, can we resect the tumor totally? And this depends on the adhesion of the tumor to the facial nerve. You see, this is the cross of the facial nerve. And here I have a nice dissection plane. Here, this is the facial nerve running on the tumor surface and still a good plane. If I see that it's very sticky, I would stop. But here you see very good arachnoid by manual technique, traction, counter traction, no prognostic bad trains in the monitoring. And dissection of the tumor. And in this case, we were lucky. We could dissect the tumor completely, although it was a large tumor, with preservation, anatomical preservation of the facial nerve. If I would have the prognostic bad trains, I would immediately stop. You see here, it's very sticky. The facial nerve is now a little bit flattened and spread over the tumor. But the tumor is resected. This is a day after surgery. You see, he has a mild weakness on the right side, but not much. And this recovered after 2 months completely. And she has still serviceable hearing. So that was a nice case. But should you always do it? When I was young, this was a lady. She had not a good plane. We had to dissect completely. 10 years follow-up, no recurrence. That is nice. But this is not a good result. This is a grade 2, grade 3, maybe more grade 3 tumor. And I think this is not our aim. We should not produce this because she's not happy. She looks in the mirror and said, oh, Schröder did this to me, not good. And that's why this was a 70-year-old. She was told she will have facial palsy for sure. She came with this lesion. We made a resection, but we left a small piece of capsule, a very small piece of capsule. 7 years now, no recurrence. And she is still a nice girl with a smile, what we want to have. Another patient, 36-year-old male, large tumor, very sticky, the facial nerve to the capsule. I left a small piece. You can't even see it on the MRI, but I know it's running here. But it's not visible. 10 years, no recurrence, no radiation. Another thing, what Marco mentioned, is cystic types, very sticky to the brainstem. Resected. Left a small piece here on the brainstem, exactly where the cyst was, and very good functional result. So that's why I think if we have these large tumors and we have in the monitoring the prognostic bad trains, I would stop, make a near total resection. There were 16 patients where I did it. We had a little bit deterioration initially, of course, but finally we have a very good outcome, only Haus-Brackmann 1 and 2. I think this should be our aim. And we had just one case so far where we need to have radiation because of progression. So my message is that endoscope-assisted microsurgery is very useful in vestibular schwannoma surgery. Not only there, also very important in hemifacial spasm, epidermoids, craniopharyngioma. So in all cranial surgery, it is very good help. It enables a look around the corner. You can identify open air cells and you reduces amount of drilling. So thank you for your attention and thanks for the invitation.
Henry, great, excellent, and as always.
Henry, yeah, he's got 4 minutes on the clock. So questions are okay.
So we have time for two short questions.
Yes, yes. Yes, he has, we can.
All right. So anyone?
The next turn will be Amir because he's got OT to attend. So
I got the message that Amir is ready. I didn't get any message from Tomasello. So French.
Okay.
I can try to share my screen as here.
Francisco, will you kindly wait, please, for Amir?
Henry.
I know that I can speak after Amir.
Yes, yes.
Okay.
Yes,
Absolutely. Okay. Any? Now it's time for one question only. Henry, do you use endoscope in all your surgeries, or are there some without endoscope assistance?
Yeah, not always. When you see you have a straight view with a microscope, then you don't need it. For example, for the medial type where I do not drill or drill only a little bit, and I know from a CT scan there are no air cells, then you don't need an endoscope. We have it always close, we have it ready. So if we need it, we can get it immediately, but it's not always. It's just if you don't look well with a microscope, you look around the corner and then it's very nice. But all cases where I want to have hearing preservation, I try to not drill the vestibule like I did in one case, but I think everybody of you has the same experience. Sometimes you have a misjudgment and then it's too far. And this is usually if you have a suction there, you lose the hearing and that is bad. That's why I stay a little bit more behind and then I take the 30-degree or 45-degree endoscope and you can so nicely see the plane. But I think the main message is you always need this irrigation. It doesn't matter where sitting position or in supine position. If I have supine, I use a suction spatula. I have a clean field, but you should irrigate because this shows you the right plane. It's like always in neurosurgery, you need to find the right plane, then all is done.
Thank you. Okay.
I have one question to Marcos.
Yep.
Marcos, do you see any indication for radiation in NF2 patients, or you never irradiate?
Almost never. Almost never. There are some very exceptional cases, but almost never. It doesn't make sense. It doesn't make sense. We work with subtotal removal and with bevacizumab. This is and then someday we have to do auditory brainstem implant. In some cases, cochlear implant.
But when the tumor is growing again, do you make a repeat surgery?
Yes, repeat surgery. Yeah, we have patients, we have done 7 times, 10 times subtotal removals.
Okay, but
if the patient accepts, we do it.
We had one patient with a large tumor and she underwent not radiosurgery, but she underwent fractionated stereotactic radiation in Heidelberg. And she lived 22 years with good hearing and this big tumor, which was not growing, and hearing preservation.
Yeah, we do have such cases as well, but they are the absolute exception.
Okay, thank you, gentlemen. We now shall have Professor Amir Sami, followed by Professor Tomasello. Amir, please. And
yes, thank you. I have to apologize. The whole system broke down suddenly when I started to talk. I'll try to share my screen again, hoping that it will work. So far you can hear me?
So far we can hear you. And we can see you.
Great. I extend my thanks, first of all, to my dear friends Imad and Vladimir for putting up this wonderful webinar. And I know you have been doing this for many years. It's a tremendous work. And I know many people are thankful for this. Today, it's a special honor for me that I can be part of this series honoring lifetime achievements, and this time for my father, Professor Majid Samii. I can only say, for me, I think is one of my greatest privileges that he is both my father and my neurosurgical father. I'm very grateful for that. And I have picked this topic, specifically neuroanatomy for neurobionic hearing restoration, because on one hand, we have a neuroanatomy committee here. On the other hand, it is one of the fields that has nicely shown his boundaries. He started surgery, he wanted to prove, and this is true with the hearing preservation, which he has fought for so long. And then when hearing preservation was not possible, and we have talked about the NF2 patients, he was very involved in the neurobiology.
Yeah, losing you again, Mamir.
Must be an internet connection problem, Vladimir, I think.
Looks like Amir is gone again.
Amir is gone again, and he probably, as Ramesh said, there are probably some internet connection problems. So let's wait till Amir will correct his problems, and let's have Francesco Tomasello. Francesco, are you ready to present?
I am not yet ready. I apologize for this, but there is some problems on my computer. I participated in many webinars and I was able to share the screen, but now it's really impossible. Excuse me. Go ahead, please. I don't want to interrupt.
Are you with us?
Vladimir, I think we should move forwards. Whoever comes first from the two speakers, we can fit them after the talks. So who's...
I think it's Vlad. It's Vlad next, I think.
Vlad, you are the one on the...
Can you hear me again?
Yes. We can, Amir. We can.
I switched. Let me
All right. Do I share my screen properly?
Vlad, Amir started talking again.
Amir is ready now.
Okay, I will stop share.
Sorry, you can hear me?
Yes, we can hear you now.
Yeah.
Go ahead, Amir.
Okay, now I just have to see if I can share my screen here.
Yes.
Okay, I'm not sure if you've heard my thanks to Imad and...
No, again.
We lost you again.
I call him again. That's okay.
In the beginning, and you can... Hello?
Hello, Amir, we can't hear you. We see the screen.
It's bad connection again.
The connection. No voice.
You cannot hear me?
Ein LAN-Kabel.
You cannot hear me?
We hear you, but when you start the presentation, everything got messed up.
Still, you can hear me?
Yes.
Amir, stop your video. Maybe you should stop your video. You should stop your video so that you get better bandwidth.
Can you see it now?
Yes.
Yes, we can.
I will try. Okay, so I hope you heard my thanks to Imad and Vladimir for putting up this great series of webinars. And I also said a few words about my father. I hope you heard those too. And I will be moving now to my lecture, which I thought was appropriate for this neuroanatomy meeting. So I have no conflict of interest. So what types of hearing loss do we have? We have conductive hearing loss, which is typically located in the outer and middle ear. Then we have sensory or cochlear loss, which is located in the inner ear. And then we have the retrocochlear hearing loss, which is typically then located distal from the cochlea. It can be the auditory nerve or at the brainstem or midbrain or cortical level. So what are the treatment options? For sensory, mild to severe, a hearing aid could be sufficient. For severe to profound, cochlear implant can be used. For single-sided deafness, a cross-hearing aid or a cochlear implant. For neural hearing loss, auditory brainstem implant can be used. And for a central hearing loss, like when the nucleus cochlearis is destroyed, for instance, an auditory midbrain implant could be used as a solution. Here you see the locations of these different neurobionic implants, the cochlear implant obviously in the cochlea, the auditory brainstem implant in the lateral recess here at the brainstem level, and the auditory midbrain implant in the inferior colliculus. So the cochlear implant has been widely used. There are more than 300,000 individuals using cochlear implants, and many achieving speech understanding in quiet environments. Here you see the promontory test. This is an important test that applies to many also of our neurosurgical patients. It's a test where you test whether the cochlear nerve is still functioning even if the patient is clinically deaf, has no serviceable hearing. So it's an electrode that is introduced through the tympanic membrane and is placed at the promontorium tympani close to the round window for electrical stimulation. So in case of a positive result, then these are good candidates for a cochlear implant. So this is the concept of the cochlear implant, where you have the electrode in the cochlea, you have a receiver stimulator under the skin, and outside you have the microphone here, and then the information is digitized and telemetrically then broadcasted to the receiver stimulator. And this is here an image where you see how you have the high frequency at this level of the cochlea, the low frequencies, and then accordingly the stimulation here of the cochlea, and then the signal is going to the auditory nerve. What is interesting now with all our discussion about radiation therapy, microsurgery, etc., this is from the Hanover series published by my ENT colleague, Professor Lennartz, where he implanted, where he did cochlear implants in different types of patients. Here you see the wait and scan patients who eventually become clinically deaf, radiation therapy patients, microsurgery patients, and NF2 patients. And you can see that the best results were actually achieved in the microsurgery series with 74% of sentence recognition, as you can see here. So, and the worst group was NF2 patients, followed by the radiation therapy patients. So these are, again, the neurobionic solutions for hearing restoration. So what to do if we have not anymore a functioning auditory nerve? Then the auditory brainstem implant is obviously an option. More than 1,500 patients have received an ABI so far. ABI significantly improves quality of life for patients through lip reading enhancement and environmental awareness. However, performance is still much lower than what is known in cochlear implant patients. And this is partly probably linked to damage at the brainstem level for NF2 tumor patients. Here you see the concept again, microphone, here the device for telemetric transduction of the information to the subcutaneously located receiver stimulator, and the electrode that is going into the lateral recess. So the ABI basically bypasses the cochlea and the auditory nerve and stimulates here the surface of the cochlear nucleus in the lateral recess of the fourth ventricle, with the dorsal cochlear nucleus and the posterior ventral cochlear nucleus directly in touch. For a while, penetrating electrodes were used in order to reach also these areas, but clinically it has shown that this was not an advantage. During surgery, you can optimize the placement position of the electrode array. Some companies have some stimulation dummies that can be introduced into the lateral recess to identify the best possible spot. Here you see again the hearing pathway. So what to do if such a patient with an ABI is not a good performer for the reasons I mentioned before? Then we have developed in Hanover the auditory midbrain implant in the inferior colliculus, which is away from potential tumor and surgical damage in the CP angle and more surgically visible than the lateral recess in the brainstem. And the AMI may provide a hearing alternative to ABI, especially when ABI is not suitable. This is a work initiated by Professor Lennartz, our ENT colleague, and my father and myself. We were involved from the early beginning as the neurosurgical partner for this. So a lot of animal studies and anatomical studies were performed prior, and eventually we ended up with the first AMI trial, which was from 2006 to 2009 with such an electrode with 20 contacts. And then here you see the inferior colliculus and the tonotopic architecture with the high frequencies in the depth and the low frequencies more towards the surface. And this was the idea, to insert the electrode in this fashion. As you can see here in the different planes, sagittal axial planes, and we have developed then the surgical approach. Here you see the first implantation, which was performed on July 4th, 2006. So it's incredible, 15 years ago. It was performed by the person we are honoring today. And here you see this is basically standard lateral suboccipital, but extended superiorly in order to place the receiver stimulator in this superior aspect. And you see this is an extended lateral suboccipital approach that allows to perform the tumor removal, but at the same time to do an infratentorial supracerebellar approach to the midbrain. And this is the first patient we operated. Again, here you see the electrode inserted, some neuronavigation and a dacron mesh to secure the electrode. This is after closure of the dura, the receiver stimulator that is placed in a bony pouch superiorly. So we had no problems, I would say, at all until today in all these patients. And we have been following them for more than 10 years. All have obtained hearing benefits, and only one had the implant ideally implanted, because as a freehand maneuver, this is quite challenging to place it in the right angle. And this patient number 3 had good pitch mapping as expected and open set speech perception in the upper range of NF2 ABI patients from Hanover Clinic. However, speech perception performance was still low. Here you see then this patient achieved 45 words per minute in the audio visual. This is the exact location again of the electrode postoperatively. So 17 contacts created auditory sensation, while 3 other contacts created side effects like stimulation or paresthesia in the contralateral knee. Here you see the neuroanatomy corresponding to the location of this implant. So these results definitely demonstrated that the principle works, the surgery is safe, but the precise placement was still not standardized, and the functional results may depend on the exact 3D location of the electrode. Here you see that when we analyzed the first 5 cases, we were more in the lower and in the medial aspect of the inferior colliculus. And following our first patients, a lot of analysis of these patients and further experimental work of our group and other groups has shown that it is much better to first of all have repeated, to not have repeated stimulation of just one site in a frequency lamina, because this causes strong refractory and suppressive effects in higher auditory perceptual centers in the animals and in our patient number 3, and that at least the stimulation of 2 sites in each lamina greatly overcomes these artificial refractory and suppressive effects. But all of this mainly in the rostrolateral and not in the caudal medial area that we have targeted originally. So based on this animal and human data, we were targeting now in the second clinical series this rostrolateral area, which is a 2 by 2 millimeter area. Here you see a regular deep brain electrode, our first generation of implant, and these were the double shank implants. So this was an NIH funded project, and here you see how in the axial plane we should have a 40-degree angle for the electrodes in order to hit all the laminas of the IC. And this is in the sagittal view. If you draw a line from the superior inferior colliculus, we should be perpendicular in 90-degree angle. This is the microanatomy with the trochlear nerve inferior to the inferior colliculus. And this is the border between the superior inferior colliculus, and this is left and right colliculus. So based on the identification of the trochlear nerve, 75% of the distance to this IC-SC limit has to be taken 7 millimeters from the medial area. This is the rostral shank, and 1 millimeter below and medial the second shank. We use navigation to achieve the 40-degree angle. We started the second trial, which was from the regulatory point of view much more difficult than 10 years before. This is the double shank electrode that you can see here, the magnetic stimulation, surgery in the semi-sitting, and then approach here supracerebellar identification of the right angle intraoperatively. And then you see we use also millimetric paper for the distances from the sixth nerve, fourth nerve, sorry, and then here from the midline, and then placement of the first shank and the second shank, as you can see here, and then intraoperative recording. So what we found was we had, again, no surgical complications, no new deficits, and all implants within the IC area. And we saw that hearing sensation occurred in the first operative stimulation test on post-op day 5 already at 20 microamps, which was 10-fold lower than in the single shank. So the direction of our modulation was right. Here you see the two shanks here in a reconstruction, how they are placed. This is again now the third patient in the second row, and the one shank had 9 created activation in 9 electrodes and the other in 8 electrodes. And we were able even to have a pitch ranking, which was fantastic for the patient. So in conclusion, the AMI trial has shown that the general concept of stimulating the central nucleus in the IC works. The surgery is technically still challenging, but it was safe for all 10 patients that were implanted. The aim to achieve results comparable to the CI or to the best performing ABI is not yet reached, but the better AMI candidates have better results than the average ABI in the Hanover group. This is already encouraging. These preliminary results from this exciting pioneering AMI journey compared to a 4 decades old history in ABI, 10 versus more than 1,500 patients, are motivating to continue our efforts beyond this trial. There are 2 more patients to be implanted. Actually, in the meanwhile, we have implanted already 1 more patient. The AMI may in future be considered as an alternative option for NF2 patients who are not appropriate candidates for CI or ABI. Now I will close with one last development which we are on. It's the translation of an intracranial auditory nerve implant. So we are leveraging previous success with the array technology. Here you see the Utah array. And basically we are planning now the auditory nerve implant, where we basically implant the Utah array into the auditory nerve. This is a project to develop and perform a first-in-human investigation of the auditory nerve implant, intracranial penetrating electrode as a hearing prosthesis using the Medial Synchrony 2 cochlear stimulator and the Sonnet 2 audio processor, and the auditory nerve Utah slanted electrode array. Here you see the Utah array. Here you see the receiver stimulator. These are the different steps we are going through now with preclinical studies, human cadaver studies, and technology development, and eventually, and we do also recordings intraoperatively, and then we will move hopefully to the clinical trial. This has been funded by the NIH. And here you can see already the first cadaver trials with the retrosigmoid approach or translabyrinthine approach, where we implant this array into the auditory nerve, as you can see here. I have to acknowledge this group, especially Professor Lennartz and Professor Lim from the University of Minnesota. Thank you for your attention.
Thank you, Amir. I guess we have a minute or two for questions.
We have 1 minute, Vlad.
1 minute, one question. Okay.
If no question,
no question.
I would like to give a short comment for Amir. When I asked him your presentation and that day in the shadow of your father, his response was, I am under the light of my father. And I was very impressed with this response. And congratulations to both of you. Thank you very much for being with us.
Thank you.
Thank you.
Yeah.
Vlad, Imad, probably I try to go ahead with my sharing my screen, but there is probably some inconvenience with my computer. So if you allow me, probably I can make the presentation tomorrow. I don't know if
no problem, with pleasure. We will add you on the program for tomorrow.
Okay. Okay. Thank you so much, and apologize again, once again.
Don't worry.
Okay, Francesco.
I'll stay in touch.
May I put a question to Amir?
Very shortly, please.
Yes. Amir, compliments for your presentation.
Sorry.
What about after the implant, the training that those patients need to learn what is the hearing possibility?
I'm not sure I got the entire question, but I think your question was the fitting and the learning, how these patients are, So this is definitely challenging. Thanks God, we have this German hearing center here in Hanover that has a tremendous experience from the cochlear implant patients, and they are running the largest cochlear implant center in the world with 4,000 cases. So they have a previous experience. What we have found is that they come in special intervals. So they have a test stimulation 5 days after surgery, they go back home, they come after 3 months, and then stepwise, after basically the implant has healed in, we can start to stimulate more and more. And what we have discovered is that these patients improve even after 5 years. Still they have an improvement, and there is no problem. Many people were skeptical that maybe the surface of the electrode and the brain, you may have a gliosis and then you have a deterioration. It was the opposite that they improve their performance. And nowadays we are also able to do telemetric fine-tuning, so we can connect with them, because few patients come from Hanover, they come from all over Germany, obviously. And this is also very helpful.
Thank you.
Okay, I now shall hand over the chairmanship to Aib Cherian and Victor as the clock judge.
Vlad, I would ask Victor to continue on, because I have just my phone with me. So it would be better for Victor to continue with the presentations while I would be doing the clock.
Okay. Victor.
Vladimir, are you going to present now, Vladimir?
Yes.
Okay. And now we have Dr. Vladimir. He is a professor and chairman emeritus in the First Medical School, Charles University, Prague. And he is also the chair of World Federation of Neurosurgical Societies of the Committee of Neuroanatomy. He's going to present carotid endarterectomy, CEA versus stent. Thank you, Dr. Vladimir.
Thank you, Victor. Do you see the screen?
Yes, we see.
Okay. I'm
Yes,
going
we
to
can
go
see that.
far away from the CP angle. I was asked by Emma to give this lecture, and I believe it's important from the point of view that we as neurosurgeons should be involved in this topic. As far as I know, in Europe, endarterectomy is performed in the Czech Republic, which is my greatest achievement since I was the instigator of that. Then somewhere in Italy, few places in Britain, and probably Switzerland. Unlike the Americans, where almost all neurosurgical departments do that. So let me talk about it. I have nothing to disclose. And this was my second enterectomy. The lady was 41 years old at the time. It was 1982. And she was sending me a yearly postcard. The last arrived this December. And the lady died just a month ago, being 80, and never ever throughout her life having any cerebrovascular accident. So it's very durable procedure. I'm going to talk shortly about the indications and recommendations as given by American Heart Association. About the trials, I just shall mention two important ones. I shall show you my own or our own series of the department, and then some issues which are not solved yet. So indications for carotid enterectomy based on several randomized trials are very simple. In symptomatic patients, it's stenosis more than 50%, provided the institution has morbidity mortality below 6%. And in asymptomatic patients, the stenosis should be above 60% with low morbidity mortality. The figure is not given. The carotid stenting came into place some 20-25 years ago, and it's of course very convenient to the patients, and it gained lots of attention. And there were two major randomized trials. The first one was CREST. You see the results, and you see that the durability of the procedure is the same as with enterectomy. What's important is that at the beginning, the complication rate of stenting is higher than that of the enterectomy. And this is the occurrence which is in all the trials which were published and in all the long-term follow-ups. The second major trial was ICSS, and again, you see that the curves are almost identical. In subanalyzing the group, there was none feature which would be better with stenting. So by all means, these two trials show that stenting is safe, but not as safe as surgery. Actually, all these clinical trials have the value of traffic signs. You are told to run 50 and you do not know whether you should run 50 or not. You must get to the place and then you will see whether you hinder the traffic or whether you will destroy your car at this speed there. So everything must be individualized. What I'm going to show you shortly is our 17-year series with more than 3,000 patients, 1,500 of them being subjected to enterectomy and 1,800 of them being subjected to stenting. These are the overall results of the whole cohort, and these results are in all subgroups, whatever we looked at it. In all respects, surgery had lower morbidity mortality rate. In the whole group, we have 1% morbidity mortality rate in surgical arm, and we have 6.1% morbidity mortality, and I'm talking severe morbidity in a stenting group. And this is repeating itself over the years, and we are unable to change that. And these differences are statistically significant. It's nothing which should be omitted or which should be hidden. There are logical indications for stenting emotionally. Contralateral stenosis, contralateral occlusion. But see again that surgery, even in these subgroups, are safer. Especially for carotid occlusion, this may be the surprise, but definitely we didn't have any morbidity mortality in surgical cases, which were 77. Probably we were more careful. In symptomatic vessel and asymptomatic vessel, again, it is the same. It's statistically significantly better for enterectomy, and the morbidity mortality rate for carotid stenting is still the same. It's spread all over the group. There are no differences, symptomatic, asymptomatic, occluded, non-occluded. This means that the risks of stenting is very stable and very similar all over the series. Unlike in the surgical group, in symptomatic vessel, we have at 1.5% morbidity mortality rate, and it decreased in asymptomatic vessels, which is rather logical and which anyone could predict. This is not the case for stenting. Elderly patients, another nice indication for stenting emotionally. Again, surgical results were better, 1.3 versus 2.3%, not statistically significant. Patients with higher morbidity overall, with carotid, with arterial disease, with heart infections, again, enterorectomy was safer. So there was no specific group which would be better in stenting for stenting. So we now have the indications for stenting very strict, but we do not heed them that much. It's wrist stenosis. We do not operate on wrist stenosis, the dissection, but it's different entity. Stenosis after radiotherapy. I have seen one patient. Previous major neck surgery, contralateral cranial nerve palsy, and of course tandem lesion when there is like carotid siphon stenosis. But then there are hazy areas. It's patient wish, which we would like to respect, and patient opt for stenting very frequently. Of course, logistics, which is not declared by everyone, and something which we call unfavorable surgical anatomy, like very high positioned carotid bifurcation, very obese patients, then we consider more likely the stenting procedure. So what are the conclusions? And they are very simple, that the morbidity and mortality achieved was much lower than that allowed in asymptomatic and symptomatic patients. Overall, we had 1% for symptomatic and 0.5% for asymptomatic patients. And AHA allows for 6% morbidity mortality rate in symptomatic patients, which still is giving good numbers needed to treat. We have published this a few years ago in ACTA, and now I'm going to go to some areas which are not really clear and which are somewhat questionable. I don't think that it's legitimate to apply criteria set for one procedure, I mean enterorectomy, to the different one, I mean stenting. It's all the criteria for indication of carotid enterorectomy were transferred to stenting without any hesitation, without any changing, and without any randomized trial. And I don't think that the hammer is the same instrument when used. And this is the same. I really don't have a good feeling about this transplantation of criteria from one procedure to the other. And the more important probably are our indication criteria, our evaluation of carotid stenosis. There are two main types how to measure the stenosis. The one comes from a European carotid surgery trial, where you count the stenotic segment against the bulb which should have been there, the whitish line. And the other is North American carotid trial, which counts the stenosis versus the normal vessel distal to the stenosis. There is difference of some 20% quite frequently. So what we did over the many years, that we were removing the carotid plaques in its entirety. We didn't cut through the plaque was removed entirely, as seen on this image. We then made the cross section and have chosen the area of the tightest stenosis, like this image here. And we then calculated the diameters and planimetry. The diameters seems to be better. Take a look on angio. If you have in this axis, A through B, the stenosis is 72%, by all means indicated for surgery. If you measure through the other line, the stenosis is 46%. It means no surgery at all. So this is a big discrepancy. So these were the measurements we were using in our feather. It's actually like a European carotid surgery trial measurement, because we are using the vessel at the carotid bulb and we are using the tightest stenosis. And this we compared to DSA, to MRA, to ultrasound, and to CTA. Actually, I now jump a little forward. The best correlation and the only correlation was found on axial acquisition planes of CTA and MRA. But it's not as easy as it seems, because the images are rather difficult and small. So you see, this is the plaque compared to all these four modalities, and now CT and MRA are most important. No one performs angiography anymore for carotid stenosis. And these were the results in 644 specimens, which is by far the largest number ever published. In low-grade stenosis, below 50%, which is not indicated to any treatment by all trials. Actually, oops, it disappeared.
It stops.
Ah, we've got a problem. Do you see my screen or not?
The screen, yes, but we do not see the.
This will stop other screen sharing. Do you want to continue? Yes, someone probably shared the screen.
No, Professor Tomasello shared the screen because his screen is seen now.
Okay, so let me get back to sharing. No, sorry for that.
Yeah, you have started sharing again.
I do. You were sharing. I will stop sharing and I will share again. I'm sorry for this. You got problems today. Okay, let me go where I was.
Yeah, good. We can see your screen.
Let me jump through all this. Again, someone is sharing with me, I guess.
Looks like Professor Tomasello. It shows Tomasello's screen. Maybe we should ask him not to share the screen right now.
Okay. Just to try, of course, I interrupted the sharing screen.
Yeah.
No problem.
Please
No problem.
So.
Excuse me.
I can't find my. Here I was. Okay.
Yeah, we're sharing again.
So I'm not going to go backwards. This is the correlation of 446 patients, and it's angiography on the horizontal line as measured on a European scale compared to stenosis on our anatomical specimen. And you see that it's completely scattered. There is no correlation whatsoever. So our angio is not really working. It is not really showing the degree of carotid stenosis. The same is true for NASCET measurements. Now I cannot move forward. You see this? Something's wrong today. This is NASCET. Again, no correlation whatsoever. And this was true for other modalities as well. What does it mean? It means that we are indicating our surgeries on a basis of completely haphazard assumptions, what we see, but what really is not true. And we are indicating this in the third most common surgical procedure with very insecure criteria, with non-negligible morbidity mortality. We do not even count much for the discrepancy between NASCET and ECSCT measurement, which are 20%. Everything is done more or less on a C stenosis basis. Almost all indications now are based on non-invasive techniques like CTA, ultrasound, or MRA. And yet the correlation between angiography, which doesn't have the correlation to the real anatomy, and this non-invasive technique was not sufficiently studied. There are few articles comparing the methods. Although the recommendations transferred from angiography were to non-invasive techniques, it's very similar as transferring the indications from one procedure to the other. From angiography, the indications which are and the criteria which are on this haphazard correlation were transferred to MR angio, to ultrasound, and to CTA. I don't believe that this is really proper step which we should have taken. Also, the recent morbidity mortality rate, which is reported around 1% in symptomatic and 0.5% in asymptomatic, means that numbers needed to treat to prevent one stroke are much lower than it used to be according to the original randomized studies from the 80s and 90s. So we should probably reevaluate something we call the stenosis below 50%, which is not indicated for surgery. New numbers needed to treat should be established. We should study length and property of the plaque, and this should be more considered as an indication criteria. We simply indicate a patient with 40% stenosis according to CTA who is having fragile plaque and repeated transient ischemic attacks. We do not hesitate, and still this is against all the level 1 recommendations. Where are we with carotid enterectomies? And it's really strange. After some 40 years of study, started by Warlow and these people in the 80s, and some 20 randomized control trials, we do not have proper indications. Unstable plaque 40%, hard plaque more than 70% stenosis, for instance, will never ever produce any problems. Compare this to ECIC study, ISAT, ISUA, Aruba. One study was enough, and the issue was either solved or raised, like this Aruba, but there are no other studies. In carotid endarterectomies, we really have some 20 randomized control trials of different quality, but there are large trials with high volume of patients. We do not have really reliable diagnostics. We only recently started to study the plaque stability and properties. Morbidity now much lower than at the time of original studies. The only study now running is ACST2, is asymptomatic carotid trial. It's both endarterectomy and stenting, but I don't believe that that will help us significantly. We have also much more medical treatment, a much more effective medical treatment. This means that we should consider between symptomatic and asymptomatic patients. Probably less asymptomatic patients will need any treatment. On the other hand, more symptomatic patients with a lower degree stenosis should be subjected to surgery. These two big studies, CREST and ICS, do not help much. The indications are more physician and institution dependent. They are more emotional. They are more proactive in many countries because it's easy and fast procedure. And what's probably the most important is that this procedure is done by vascular surgeons, which is all right, but they never ever consider the difference between femoral artery and carotid artery. They do not consider where the artery runs. By cardiologists, and for cardiologists, the carotid artery is the peripheral artery, not the important one. By many interventional neuroradiologists who lack the clinical education, and by many other specialties. So this is somewhat wrong, because we should go for plaque studies, we should go for flow studies, which don't help much because hemodynamics is not that important, but embolism, so plaque studies. Both endarterectomy and stenting are improving over time, and numbers needed to treat are lower. Medical treatment, pseudo-occlusion, for instance, which was diagnosed only by angiography. We are missing this condition with CTA, ultrasound, and MRI, and doesn't show it. So many patients are considered to have had their carotid artery occluded, and it's not occluded, it's pseudo-occluded. And this accuracy. So I believe that we as neurosurgeons should be involved in this field, because the target of the treatment of the carotid artery is the brain. And the brain is the domain of neurosurgeons. So do please think about it. Do please go for endarterectomy, because it's an easy, nice, and very elegant procedure. And it really does treat the brain. It's durable. It's really very good protection against one of the most serious conditions in the the humans which is completed stroke with hemiplegia and aphasia. Thanks for listening to me. This is a little advertisement. So thank you for your attention.
Excellent presentation, Vlad, as usual. You put the ball in the court for everybody actually here. So the stenting and the studies that support the stenting is always is always praised by everybody, except, I mean, especially the neurologists. And unfortunately, in our countries, the neurologists see these patients and they always recommend stenting, where you have very rightly said carotid endarterectomy has a huge role in, probably it's much more safer. And I think my view is that instead of looking at this randomized control trial or doing randomized control trials, as surgeons, we should start doing endarterectomy and let somebody else analyze the results for us. Yeah. So excellent presentation, bang on time. I would probably now ask, would you like to take the chairmanship back so that—
No, it's up to you and Victor now.
Yeah, maybe Victor can introduce the speakers and I'll be on the clock.
Okay, thank you so much. We continue with Professor Abdulsalam Al-Karamlichi from Morocco. He's going to present central nervous system infection. He is Professor and Chairman Emeritus, Director of WFNS, and Honorary President of the WFNS. Thank you, Dr. Abdulsalam. Go ahead, please.
Thank you. I'm trying to share my—
You have started sharing the screen.
Yeah, but it doesn't work.
It is working, El-Kamlichi. It is just that your presentation is, you have to share your presentation.
Yeah.
Yes. Yes.
Yeah, it's here. Thank you. Thank you, Mr. Chairman. Dear friends, colleagues, it's a great pleasure and honor to participate in this outstanding webinar dedicated to our great master and teacher, Professor Majid Sami, the icon of neurosurgery worldwide, and who put his mark in the current evolution of neurosurgery. So we would like to express my deep thanks to my friends Imad and Vladimir for their invitation and for allowing me to be in this distinguished group of colleagues. Well, I will put you maybe away from high-tech micro neurosurgery, endoscopy, and so on, to speak on topic of central nervous system infections. When my friend Imad proposed me to speak on this topic, I said, yes, okay, I'm very happy to speak on that, because it brings me to the beginning of the 90s, when I was for the first time invited as a faculty in one of these famous international neurosurgical courses, which were organized usually by Professor Sami. And he asked me at that time to speak on, to give a lecture on CNS infection. So I think that it's a really suitable topic also today for this webinar. Well, the CNS infections are, of course, can be defined as an invasion and destruction of the CNS tissue by an infectious agent. These diseases are among the most severe diseases we face in our neurosurgical practice. And of course, they're very frequent, and in some places, they come just after trauma in the neurosurgical practice. And more than that, they are very severe, and they're leading cause of mortality, morbidity, and
Era para
handicap.
confirmar que hemos recibido
Sorry.
el informe y las pruebas efectuadas en
Someone
Santa
is
Elena.
speaking. Sorry.
Miguel, you need to mute. Miguel.
I have muted Miguel.
Okay.
Sorry. And more than that, they are very severe and a leading cause of mortality, morbidity, and handicap in many places, mainly in low and middle income countries. Of course, this is a very large topic, and it's made by a large number and heterogeneous diseases. And you see that these diseases and these infections can be localized and evolve as space-occupying lesions with, of course, a particular relevance for neurosurgeons. They can also, they may onset acutely with a rapid development requiring a fast and adequate treatment for patients when they arrive on the emergency ward. They are caused by a large variety of microorganisms. Bacterial infections, of course, the most known and very frequent, meningitis and encephalitis caused by viral infections. They can be caused also by parasitic infections with a large number of these parasites, large variety also of fungi infections, mainly in immunocompromised individuals, and also some specific bacteria like TB infection, in addition to the CNS envelopes infections. Regarding the pathogenesis of these diseases, of course, the most simple and easy way for the microorganism agent to attend the intracranial or intraspinal space is the contiguous spread with the direct invasion from the suppurate focus. And this comes in general from infections in skull base area, otitis, sinusitis, and so on. In such cases, of course, the diagnosis in general easy with just a pulse sampling, and the treatment also adding to the antibiotics the excision of the infected tissues. The most frequent and the second group of spreading of the infection is the hematogenous spread. And in such situation, most of these infections are in general diffuse, meningitis, encephalitis, or thrombophlebitis, and so on. But when they are localized, most of the time, they're, as you see here, multiple and also in general deeply located. And then the last group of the dissemination is presented by the post-traumatic infection diseases, which are generally secondary to the penetrating head injury or penetrating rarely spinal injury, or they occur in post-operative period in our practice in neurosurgery. This slide is very important because it shows us again how the anatomy is important and how the structure, the anatomical structure where the microorganism will be located in intracranial space will determine the type and the entity of the CNS infection disease, depending if it's located in the epidural or subdural area, in leptomeninges, in CNS tissue, brain, or spinal cord, and we will have, of course, diffuse infection, meningitis, encephalitis, or localized abscesses, granuloma, tuberculoma, and different parasitic cysts. It's quite difficult to deal with the management of all these diseases. I would like, before giving you two examples of these CNS infections, to say some word about the significant progress which has been achieved in the last 2 decades. And the most important progress, which was deducted from a large studies on cohort of patients, was the conclusion that the prognosis of these diseases is closely related to the early diagnosis and early treatment. However, this early diagnosis is not easy because the clinical symptoms and features are almost similar, associating some systemic symptoms like headache, like meningeal syndrome, or neurological deficits, which are variable depending on the location. So the keys of the diagnosis, first is the CSF testing, which is the key component of this diagnosis, but it should associate microscopic examination, culture, and especially nowadays, antigenic and genomics tests, very important. And then the second key of the diagnosis, the imaging, either CT scan and MRI, mainly in the infections where the results on CSF tests are not reflecting the, of course, the process, the infectious process, which is located in the parenchyma in the brain. The second most important, I think, progress in this topic was the elaboration and the dissemination of the diagnosis and treatment guidelines. This is very important because it was, of course, endorsed by many medical societies, so disseminated in all over the world, and this facilitated the implementation of the local protocol in different countries, in different hospitals. This is very important because this will facilitate the care of the patients, and this allowed a large number of practitioners, of course, to be able to treat these patients quickly and adequately when they arrive to the emergency ward. And then the last but not least progress came from us, from neurosurgeons, which was in the last decade the applying of the minimally invasive techniques for this pathology, especially the stereotactic biopsy and the image-guided open surgery. So I will just, due to the time, I will just give you, share with you some of our guidelines in the management of these diseases, taking the example of brain abscesses, and the second, the example of brain tuberculoma. And you see, for example, that in this series of brain abscesses, we collected more than 30 years this high predominance in the young patients, almost the half of cases, and then also a clear predominance on the male patients. You see here the typical images and the importance of a CT scan and the importance of the contrast enhancement to diagnose these diseases. Of course, the same on MRI, but the MRI with its new techniques and advancement in sequences and in type of morphology images is very important to allow how to differentiate these images of brain abscesses from the other pathologies who can show the similar images as you see in these two slides. The location of brain abscesses, almost 2/3 are located in the supratentorial area and 1/3 in the infratentorial area. And you see that almost 1 patient out of 10 has multiple lesions. And here you see our treatment protocol, the combination of 2 or 3 drugs, and then the surgical treatment most of the time associated. The burr hole aspiration, most of the cases, some kind of craniotomy and excision of the lesion, especially in all the lesions when patients arrive late and in the recurrences after burr hole aspiration. Of course, the stereotactic aspiration, which is start to be applied in the last decade, is a very, very important technique. And 6 patients, just 6 were treated without any surgical treatment. And you see here some examples here, a left large temporal lobe abscess after burr hole evacuation. This is just the CT scan after 1 week. And then you see after 1 month, after 3 months, you see that the medical treatment with adequate antibiotics should be followed, of course, more than 1 month, at least 2 or 3 months. Another case in the left prerolandic area, and you see here 2 months later, still the infection, 3 months later, and then 8 months later. And you see here just the final result on all these series, showing that brain abscesses is still a severe pathology, 10% mortality still, and almost the same also a number of patients with severe sequela. Regarding the brain tuberculoma, you see that TB is still one leading cause of death and disability worldwide. This was the map of WHO in 2011 with 9 million new TB cases every year worldwide. And you see that the situation didn't change. In 2019, they have published a little more, 10 million individuals with TB new cases during the year. So our young generation of neurosurgeons must be aware about the brain tuberculoma and consider it in different diagnoses of intracranial mass lesions. And you see here some of our guidelines on diagnosis and management. First, no typical clinical feature. An active tuberculosis, systemic tuberculosis, is just associated of the cases in 1/3 of the cases. And in spite of the MRI progress, imagine finding alone couldn't confirm the diagnosis. This is very important. We have here, of course, this typical ring enhancing lesion. Sometimes they are multiple with a multilocular aspect, which is, of course, typical of tuberculoma, mainly in endemic countries. But you see that the shape of the lesion can be completely different, as you see here, and can advocate any other lesion. So a third guideline, very important, there is no place today for conservative treatment or empiric treatment, which we are seeing, unfortunately, still in many places in the endemic area. There is no place for this treatment, and the positive bacteriology or histology is mandatory before starting any anti-TB treatment. And if we look to our series of 800 cases, we divided them, taking in consideration these guidelines, on 3 groups. Group A, 30 patients, where, of course, we have some typical clinical symptom, typical image, and we have also extracerebral tuberculosis, which was associated in almost all the cases. And you see here that the patients were directly treated with the anti-TB treatment without any other investigation or any other additional surgery. But you see here, for example, this case, the pulmonary TB, and you see here 3 months later, the decrease on the size and the changing of the image. 6 months later, brain tuberculoma needs more duration, at least 1 year duration, as you see here, of the medical treatment. The second group, the group B, which was less typical, and most of the images were deeply seated, small images, and in this group we had the confirmation diagnosis in addition to the genomics by stereotactic biopsy, which confirmed the diagnosis, and then the patients were treated. And you see here some kind of these images, as you see here in this young girl, 16 years, you see the type of images, and the stereotactic biopsy confirmed the diagnosis, and you see here the changing, the progressive changing until 15 months after the beginning of the treatment. You see here another case, the stereotactic biopsy confirmed the diagnosis, and here the image decreasing 6 months later, but the treatment should be continuing. And again, another case. The third group, where there is almost no typical clinical signs, no extra cerebral TB, and these the images show very large lesions, which were absolutely not suggestive of tuberculoma, and most of the time located in accessible area. And all these patients were operated, and the diagnosis was confirmed after surgery, and then the treatment. And you see this kind of images. It's not easy to say that it's tuberculoma, completely far from the shape we found, and I have shown at the beginning in the images of tuberculoma. And when you operate these patients, you see such kind of yellow lesions, which you can in general remove just partially to decrease the intracranial pressure, and then leave the rest for the anti-TB treatment. And you see here the typical histology of these lesions. So in conclusion, the brain infection are still frequent and life-threatening. Their incidence, of course, can decrease with prevention, vaccine in some cases, and the early diagnosis and treatment of the infectious focus. Early diagnosis is the best way to achieve the low morbidity and mortality. In those involving as a spice-occupying lesion, a combination of surgical treatment, chemotherapy, followed by constant clinical and imaging control should result today in the cure of the majority of the cases, almost 80%, as we have seen, without any sequelae. My last slide is a kind of advocacy to the young generation of neurosurgeons, to tell them that this topic deserves more interest from neurosurgeons, and it should be not only part of our educational programs, but it should create more desire for research and high quality of publication in order to improve the management and the prognosis of these patients. Thank you.
Yeah, we finished all the 20 minutes for you, Professor El-Kamlichi, so we will not have any questions. So I guess Victor can move on to the introducing the next speaker, please.
May I just interrupt? Just
yes,
for people,
yes.
they should answer the question at their convenience at the chat, please. There are a few questions for the previous speakers to answer. Thank you.
Yeah, thank you. We continue with Dr. Miguel Arraez from Spain. He is professor and chairman of neurosurgery in Carlos Haya University Hospital. He is president-elect of World Academy of Neurosurgery. He's going to talk about surgery in and around Meckel-escape tumors toward a safe removal. Thank you, Dr. Arraiz. Go ahead, please.
Thank you very much. Thank you very much to the organizer, my very good friend, Dr. Imad Kanan and Vladimir Benes. Congratulations for this outstanding session honoring the amazing neurosurgeon and person, Professor Majid Sami. I hope you can see my slide and hear me well, right? Okay, thank you very much. So I will take over the next 15 minutes to talk about surgery in and around Meckel's cave. This is a neuroanatomy committee session, so I think that this presentation perfectly does fit because it's very much a domain. The surgery in and around Meckel's cave is very much a domain by anatomy. It's not an easy anatomy. You can see here one of the slides from Professor Tolling, just top left. You can see this beautiful preparation, this one, top right, bottom left, from the wonderful neuroanatomy group of Pablo González in Alicante. I'd like to thank him because he provides me a lot of wonderful material for my presentation. And this is another slide showing how complex this anatomy could be, not only at the petrous apex that could be placed over here, but also taking into account all the intra and extradural neural, vascular, and nerves component of the anatomy. So this is a very nice picture from one of the publication of Acta Neurochirurgica. So in summary, a complex area, and we will start mentioning something about the role of microsurgery. Irrespective of the location of the tumor in and around Meckel's cave or petrous bone, we have to follow these steps. First of all, we have to do a craniotomy, can be COC or not, according to the lesion. We will mention something about that. The most lateral structure is the middle meningeal artery, medial to and very close to the meningeal artery is the third division of trigeminal nerve. We have to make a peeling of the trigeminal nerve that was, let's say, devised in the 80s and popularized in the 90s, allowing, the exposure of this area. We have to preserve the GSPN. We can see here the GSPN that is very close to the anatomy of the carotid artery, that is the most medial structure, relevant structure, the petrous carotid artery. And we can divide the petrous apex region and Meckel's cave in first petrous lesion. This is a very common example, symptomatic cholesterol cyst, and this is the way we can do the incision. In that case, we did remove the zygomatic arc. We used to do a very limited zygomatic osteotomy, whose anatomy, whose interest is only just reflecting downward the temporal muscle. If temporal muscle is not very bulky, you don't need to do this surgical gest. This is the way of trying to reflect downward temporal muscle, craniotomy, and after the peeling, you can see third division, second division. This is temporal dura, right side. Of course, this is a cholesterol cyst already exposed, carotid artery, and GSPN. This is a very nice anatomy. Cholesterol granuloma, this is a patient we operated on more than 25 years ago, cholesterol granuloma. At that time, we used to cut the third division of the trigeminal nerve. After that, we used to suture with the hope of getting some recovery of the function. And this is the way, cutting the third nerve, the only way you can see the second loop of carotid artery right before entering cavernous sinus. This is the lesion, apparently completely removed, symptomatic cholesterol granuloma. But the patient was coming from outside of Granada, my former hospital at that time, and the patient was lost for the follow-up and came back later on. And this is the huge recurrence of the cholesterol granuloma, this time operated on through a retrosigmoid approach. You can see the lower cranial nerves. So do not think that cholesterol granuloma is always the indolent lesion we are very much accustomed to see. Chondrosarcoma is another typical example of the petrous bone. You can see this lesion, typical appearance, and this is the way you can make a complete removal. This is immediate postoperative CT scan. This is another example of chondrosarcoma, this time just penetrating petroclival dura and getting inside posterior fossa and giving some idea of the concept of transpetrous resection of lesion at the posterior fossa. This is the way you can remove the lesion and even the component inside posterior fossa. Second group of examples is the extradural interdural group. This is exactly restricted to lesion growing inside Meckel's cave, that is synonymous of lesion in 99% lesion of the trigeminal, of the Gasserian ganglion of the fifth nerve. And this is one of the examples. You can see the context of interdural, talking about Meckel's cave. This is a psychiatrist of another hospital here in Malaga with episodes of diplopia and headache. See the lesion with some hemorrhagic component. See the context, as I mentioned before, of the interdural disposition of the tumor. And well, this is a matter of anatomy, the way of approaching lesion at the Gasserian ganglion and third division of trigeminal nerve. You can see the relevant anatomy. This is dura mater. We can see porus trigeminalis, where the fifth nerve is getting inside the trigeminal system, and this is Meckel's cave. Meckel's cave has an outer dura and inner dura, and this concept of removal is an epidural approach, that is to say, just lifting the dura and between the dura and the bone, just approaching the lesion. There are many different publications: epidural, interdural, frontotemporal approach, infratemporal fossa interdural approach. I think that one of the beauties of skull-base is the possibility of having the same approach and using the same concept, but making thousands of different publications with eponyms or different ways of making, you know, the nomination of the approach. But the basic is extradural approach to the Gasserian ganglion. But sometimes you can have problems. This is a slide courtesy of Professor Kawase, who mastered this approach, as we all know. We have to very much pay attention to the venous anomaly at the middle fossa. We have sphenobasial veins, we have infratemporal vein with a lot of anatomical variation. Frequently, there is some veins around the third division, reason why the third division, apart from the middle meningeal artery, is very much bleeding. But in any way, we can have some prominent sphenobasial vein or infratemporal vein. And this is what happened in the case of our psychiatrist, making a complete nightmare the extradural approach. So you can see the veins, and what you have to do in those cases is just open the dura, releasing CSF a little more, and just reflecting temporal, or just sparing the temporal lobe and exposing the lateral aspect of cavernous sinus, the outer dural layer, and by means of a small incision, you can make a removal of that very easy to remove lesion that fortunately allowed us just to preserve the fibers of the fifth nerve. And this concept is also applied to some other more complex lesions that are interdurally placed. You can try an extradural approach. If you have a problem, do not hesitate to open the dura. You can get such a nice exposure, as you can see here, right side, in that case, fortunately preserving the second and third division of the trigeminal nerve, as you can see in this clip. The third group could be the extradural, intradural type of lesion. I like to, mention for the youngest colleagues in the audience that there are several relevant publications talking about that. You cannot miss this publication. 1999, Professor Yoshida and Kawase, I had the chance to meet them. It was valid 10 years ago. This publication, trigeminal neuroma, that is the typical example for that kind of funny growing. Trigeminal neuroma extending into multiple fossae. I think the trigeminal schwannoma is the only lesion that can be at the same time intracranial, extracranial, and or intradural and extradural according to the caprix of the growing, being the epicenter, the Gasserian ganglion, as you can see here. This is one of the lesions that have some sort of hourglass fashion. This is tentorium, as you can imagine. And this is the way you can make this transpitreous resection following the tumor. In that case, we managed to clip the superior petrosal sinus, but you have to pay attention to that. You have to do that 1 centimeter or more far from the clinal process. Otherwise, you will damage the fourth nerve that in that case, unfortunately, was damaged. This is third nerve, and this is some Surgicel just covering the pontine, anterolateral pontine region and postoperative CT scan. This is one of the rare occasions that nowadays we do COC, that is to say, including in the context of the zygomatic osteotomy, the orbital component, in that case, because of the growing of the lesion inside the orbit. Otherwise, we do, if any, some small limited zygomatic osteotomy. But in that case, of course, we have to unveil the orbit, and this is the postoperative MRI. We left some small part at the superior orbital fissure with the hope of preserving. The patient had some complex ophthalmoparesis that was impaired due to the operation, but in any way, we try to preserve the nerves. We left this small component of the lesion, as you can see here, and the patient, you can see the patient years after, the patient was lost for the follow-up, and the patient back with this huge recurrency involving posterior fossa. You can see here, this is the tumor, and the way we just again went back and managed to remove. This is anterolateral pontine region. This is a vertebrovascular system. And in that case, to remove the orbital component instead of COC, we just we use the endoscopy system to as a complementary adjunct tool, trying to remove the orbital content of the tumor. This is the postoperative MRI, pretty satisfactory. This is another example. Seems to be trigeminal neuroma, but actually was an atypical meningioma in a very young patient, 18 years old patient. And the same way, you can have a pretty satisfactory removal by means of this approach. Last part of this microsurgical journey is regarding extended middle fossa approach. That is to say, how to first of all expose the petrous apex, and after that making some cut that includes the cutting of the superior petrosal sinus in order to get inside posterior fossa. This is a picture taken from a publication from Dr. Sekar and Dr. Sen, 1994, at that time depicting the possibilities of this approach by means of this small window. To my mind, there are a few indications, but this is a very good approach. One of them is related to lesions that are primarily growing at the petrous apex and then growing inside posterior fossa. So we can get access to the petrous apex and then just removing the posterior fossa component. This is one of the examples where we are at the right side, and this is the way we do this extradural approach. identify middle meningeal artery, not very easily in that case because it was very adherent to the third nerve. This is middle meningeal artery already cut. This is the third division of trigeminal nerve in the context of the peeling. I will move forward. We are just exposing. This is GSPN, this is petrous apex, this is dura, temporal dura. Until which extent we have to expose the petrous apex? Well, we have to do that until you manage to put one of these dissector, as we can see here, until you can put the dissector over the wedge of the petrous apex. This is the limit of the extradural peeling of the third nerve, and then you start drilling. This time we are seeing how the drill is working in normal bone, but then you see how easily the drill is getting inside a softer tissue because just we found the tumor, drilling around petrous apex, posterior and medial limit is the internal auditory canal, of course, medially the dura. Move forward. This is the dura already exposed. We are drilling the petrous apex. We have to pay attention because at the deepest part, you can get inside the jugular verb and or inferior petrosal sinus. That is, of course, a trouble because of the bleeding. We continue drilling. Okay, move to the next step. Now we have exposed the petrous aspect of the carotid artery, and we are drilling medial to that, that is where anatomically the petrous apex is. Everything seems to be very clean. This is the third division. The lesion, achondrosarcoma, is supposed to come from the petroclival synchondrosis. If you want to see that, you have to cut the nerve. You shouldn't do that, of course, and or you can have a look by means of the of the endoscope. This is one of the example. Another example of assisted endoscopic assisted microsurgery. We saw beautiful presentation of Dr. Schroeder about acoustic neuroma, and this is the way you can continue drilling this unresected part of the tumor. Then you have to open the dura. You have to first do some cut parallel to the inferior surface of the temporal lobe, as you can see here. Okay, you see here the third division of trigeminal nerve. You start cutting, but before that you have to first take into account that the superior petrosal sinus is over here somewhere, and second, very easily the third division, the fifth nerve can be damaged because its segment, cisternal segment, has a pronunciated curve toward the trigeminal ganglion. This is the way we have already exposed the fifth nerve. We are coagulating the petrous, superior petrosal sinus that wasn't much prominent, not need for clipping. This is the petroclival dura, and see the curve of the fifth nerve and third division of trigeminal nerve. We continue, just opening the dura. You see the way we can expose the fifth nerve. Okay. And now in this time, we just managed to displace the bulgy component of the posterior fossa toward this safer area of the petrous apex, ultrasonic aspiration, and then the last part that is removing this sticky part of the tumor. This is the lateral aspect of the pontine region. This last part not easy because of not very good playing, but in any way exposing the anterolateral pontine area and removing the tumor. This is the pre-operative lesion, and this is the post-operative MRI, very satisfactory after removing the petrous component and posterior fossa component. So this is, to my mind, this is the best indication. Lesion primarily at the bone, at the petroclavial synchondrosis and petrous apex, and then growing inside posterior fossa. Some other examples, this is a chordoma, laterally placed in an old patient, and this is the removal, pretty satisfactory. And this is one of the examples for that approach, anterolateral cavernoma, anterolaterally placed cavernoma at the pontine region. This is from the context, from the anatomical conceptual point of view, this is a good indication, but for lesion like this one, we have learned that simple retrosigmoid approach is good enough to remove the lesion, but in any way, second indication could be brainstem lesion at the anterolateral pontine area. Third indication, to my mind, some sort of meningioma that for Professor Kawase was the first indication, but honestly, I do not see many meningiomas as a good indication for that approach in my practice. Dear moderator, I don't know whether I have several minutes for the 7-8 slide. Do I have?
We are on time, Dr. Arraez.
So, well, a couple of minutes is okay, or do I finish?
Dr. Ayman.
Sorry,
Okay.
we'll give you 1 minute to conclude.
Okay, of course. Well, just only some slides regarding the possibilities of the endoscopic approach for that sort of lesions. But in any way, this is the exposure from front door, let's say, exposure of the Meckel's cave. But in any way, my last slide regarding the possibility of microsurgery of endoscopy. We just have this question list, whether about the lesion is invading sphenoidal sinus, whether or not there is intradural growing, whether or not this posterior place extended toward jugular foramen, whether or not there is vascular encasement that could be a risk for carotid artery. And my last slide, just making some comments about the surgical approaches to the petrous apex region and Meckel's cave. This is a neuroanatomy committee for the youngest colleagues of the audience. As you have seen, all these cases, anatomy is presiding the surgical approach. Microsurgical approaches and endoscopic approaches can be used both for lesion according to the characteristic we mentioned before to get access petrous bone, petroclavial region, pontine region, lateral wall, cavernous sinus, infratemporal, anteropalatine fossa. Thank you very much for this wonderful webinar and the opportunity to share my experience in that area of the Meckel's cave. Thank you very much.
Thank you, Dr. Miguel Arraez. We do not have any time for questions or comments, but you can do it through the chat. Now we continue with Dr. Ricardo Romina. He's going to talk about surgical anatomy of the jugular foramen. He is professor of neurosurgery in El Bosque University, and he was president of the 17th WFNS Congress in Bogota. He's going to be the president. Thank you, Dr. Romina. Go ahead, please.
Can you see my screen?
Yes.
Okay. Thank you very much for the invitation. I would like to thank Dr. Imad, Dr. Vladimir for this very nice symposium, and in honor of Professor Sami. Professor Sami has a legacy and tribute to Dr. Oliver Krona, Dennis Sherman, and he developed a school for the old world. And we created in 2002 a society, that's the MASI, that's the Mahdi Sami Society of International Neurosurgery. And since this time, we have organized 7 congresses. The next one would be in Miami. The first one was in Tübingen, with Professor Tatajiba. The second one was here in Curitiba, and then in Seattle, in Kobe, in Japan, in Amman, in Montenegro, in Cartagena, and the next one in Miami. That's show how Professor Sami has this school around the world. We are working in Curitiba, South Brazil. Curitiba is a large city. We have over 3 million people here in the city. And in our institute, we have educational programs for Brazilians and foreigners. We have a residency program for the Brazilian and also for the World Federation. We have a residency program in neurosurgery for 5 years. We have 1 resident per year. And we have also for the WFNS, postgraduate fellowship of 3 months. Today, I'd like to share with you our experience in the jugular foramen tumor surgery and talk about the surgical anatomy. I'm the current president of MASI. There is nothing to disclose. And how about the anatomy of this region? The jugular foramen is a transition zone between the structures of the ear, posterior fossa, and cervical region. Surgery of the jugular foramen tumors represent a challenge for the neurosurgeons and ENT surgeons due to the complex bony and neurovascular anatomy. That means you should know very well this anatomy. The jugular foramen is located in the medial and inferior surface of the petrous pyramid. In the transition of the occipital and temporal bones, we have different structures around the jugular foramen, like the internal carotid artery, like the internal auditory canal, and also the structures inside of the foramen. The jugular foramen is divided in 2 portions. The pars nervosa of the jugular foramen, it contains the 90 cranial nerve, the tympanic branch, the Jacobson nerve, the inferopetrosal sinus, the meningeal branches of the ascending pharyngeal artery, and we have the pars vascularis of the jugular foramen, with the sigmoid sinus, the vagus, and the auricular branch of the Arnold's nerve and accessory nerve. These nerves, Jacobson and Arnold's nerve, usually are the site of origin of the paragangliomas of the jugular foramen. The vascular anatomy. Most of the jugular foramen is occupied by the jugular bulb. That means the union of the sigmoid sinus and inferior petrosal sinus is continuing with the jugular vein. You can see in this dissection we did in our laboratory, you can see very well the sigmoid sinus, the jugular bulb, and the internal jugular vein. The jugular bulb has a size of approximately 15 millimeters wide and 20 millimeters high. The right side is usually wider in the most patients. The internal carotid artery has a close relationship with the jugular foramen. It enters the skull through the carotid canal inside the petrous bone and has 3 segments. The ascending segment is vertical, the general of the carotid artery, and the horizontal segment. In this portion, the carotid arteries has some branches, the carotid tympanic branches. These branches can feed tumors like the paragangliomas. You can see in this dissection, the internal carotid artery entering the skull. You can see the facial nerve, you can see the internal carotid artery inside of the ear, and the posterior fossa with the opening of the jugular foramen. The vertebral artery is also very important in this surgery because it's very intimately related to the jugular foramen. In some cases, we have to dissect the vertebral artery and remove for its canal to expose the jugular foramen. You can see here on the right, the internal jugular vein going to the jugular bulb. And we remove the vertebral artery in this patient to expose completely this region of the tumor. The nervous anatomy, you can see the intradural anatomy. The 9th, 10th, and 11th nerves exit the medulla and the upper cervical spinal cord, going to the cerebellomedullary system and going to the internal to the jugular foramen. You can see here also the exit of these nerves from the medulla and from the upper cervical cord. If you open the jugular foramen, you can see how these nerves are located inside of the jugular foramen. The 9th nerve is usually superior and medially. The 10th and 11th are more distal. And all these nerves are medial to the jugular bulb. That's very important when you are removing these tumors, because you have to remove the jugular bulb. The facial nerve is related also to the jugular foramen. You can see here the facial nerve, the external auditory canal, and the jugular bulb and the sigmoid sinus. If you want to operate this patient, you should know exactly this anatomy, because that's very important to preserve. You can see here a surgical specimen. You can see the 7th nerve inside of its bony canal, and the external auditory canal, and the tumor and the jugular bulb exposed. The cervical anatomy is another difficulty in this case, because very often these tumors grows to the cervical region, to the neck region. You have to dissect the neck to remove the tumor. Then you should know exactly which muscle we are dealing with the sternocleidomastoid muscle, digastric muscle, the sphenocapitis, obliquocapitis superior, inferior, the rectal capitis. And that's very important to know exactly, to preserve. To localize, to dissect the vertebral artery, you should know the anatomy of this muscle at C1, the superior oblique muscle, the rectus capitis, and the inferior obliquus muscle. They are inserting in the C1 process, lateral process. Then we have the arteries in the cervical region. We should dissect the common carotid artery, the external, the internal, and its branches, and the external carotid artery, and the vertebral artery at the junction, cranial-cervical junction. You can see here in these slides, all these vessels, the internal jugular, internal carotid artery, the internal jugular vein, the vertebral artery, and after removal of this canal. And the veins are very important. You can see the facial vein, you can see the internal jugular vein, and here, after a complete removal of the bone, you can see the jugular bulb, the sigmoid sinus, and the internal jugular vein. And look at the relationship between the internal jugular vein and the internal carotid artery entering the skull. It's very close. You should know it, because these tumors are very close to the internal carotid artery at the skull base. If you resect this tumor, you should preserve all these structures. And then you have the nerves in the cervical region, the 7th, the 10th, the 11th, and 12th nerves. You can see here the 10th nerve, then 12th nerve, and the 11th nerve. We have to dissect these nerves in the internal jugular vein and the mastoid tip on the right. Facial nerve, we have to preserve the facial nerve. And to dissect this nerve, we use usually the mastoid tip, the pointer of the external auditory canal, that's the cartilage of the external auditory canal, a digastric muscle. the nerve, the facial nerve, will be always in this position. We have to dissect to identify this nerve to preserve it. You can see here the facial nerve, and on the right side you can see a tumor invading the nerve, and after a graft. And that's the final exposure. You can extradural exposure. You can see the jugular vein, the internal jugular vein, the left nerve, the jugular bulb, posterior fossa dura, the hypotympano, the facial nerve, and the external auditory canal. That's the final exposition of the surgical exposition of the jugular foramen. And how about the treatment? The treatment of these tumors. We have published this book some years ago, and we should know the path of the tumor extension. These tumors are growing very often from these nerves, Jacobson and Arnold's nerve, going inside the jugular bulb, inside the sigmoid sinus, the jugular vein, growing around the carotid artery, in the middle ear, and in posterior fossa. That's the difficulty of managing of this tumor. In our series, we have so far 181 cases. We have the most of these cases are paragangliomas and then schwannomas of the jugular foramen. We use two surgical approaches to remove this tumor. If the tumor has no cervical extension, we modify red sigmoid approach, usually for schwannomas and meningiomas. Tumors with the cervical extension, we use the craniocervical approach. Mostly of these cases are paragangliomas, schwannomas, and meningiomas. That's how we use this red sigmoid approach, this modified red sigmoid approach. That's we open the jugular foramen from the inside, drill the jugular foramen, and remove the tumor. That's like drilling the internal auditory canal. That's very useful if the tumor is not going down to the cervical region. But most of the cases are in the cervical region also. And then we have to use the craniocervical approach. We have published this craniocervical approach many times in different journals, and also in the Sum's Essential in Neurosurgery. We have published the second edition. We are preparing the third edition now. That's how we do this incision, the position of the patient. And this video shows how we perform this incision and dissect. That's the cervical region, that's the temporal fossa, and then we perform open of the temporal fascia and the cervical fascia. We have developed this reconstruction of the skull base for these tumors, because after removal of the tumor, you have a large defect at the skull base. You have to reconstruct it to preserve it, to avoid CS fistula. And then we develop this strategy to reconstruct this skull base. That's important. How we do it, that's the temporalis and cervical fascia, and then the temporalis muscle. We rotate down the 2/3 of the posterior temporal muscle. If it's not reach the region, we can make a back cut and then put the muscle over the removed bone, like this one. You can see here. And then we bring back our muscle and fascia and cover this region on two vascularized planes. And this very good result, cosmetic result, you can see here. It's almost no scar after surgery. Then we have this slide showing the extradural exposition. You can see tumor behind the tympanic membrane, tumor in the neck, tumor in the posterior fossa. The next step is to perform a mastoidectomy and a craniectomy. You can see here. That's a radical mastoidectomy we perform because the tumor is going inside of the ear and the mastoid. And then we perform a craniectomy about 2 centimeters in diameter, exposing the sigmoid sinus. Then we have to manage the facial nerve. If the facial nerve is not infiltrated, we just perform decompression, neurolysis. But if the nerve is infiltrated, we have to make a graft or a primary suture. Like in this slide, you can see here, we perform a grafting, and the results are usually good. The next step is ligation of the sigmoid sinus. Then we use an hemostatic clamp to ligate the sinus. You can see here with double ligature. It's important to be very safe. Here the sigmoid sinus ligature. And then we perform a ligation of the internal jugular vein and double suture ligature to avoid bleeding from the internal jugular vein after surgery. Next step is the extradural removal of the lesion. You can see here, the lesion is growing inside of the sigmoid sinus. It's lumen, and then we remove with the jugular vein. The jugular vein is infiltrated by the tumor and complete removal. And then the intradural removal of the tumor. You can see here, we open the dura in the middle wall of the sigmoid sinus to avoid cerebellar retraction. And then you can see here the tumor. That's the tumor. That's the jugular foramen. If the ICA is infiltrated, in some cases you have to perform a bypass, a high flow bypass, to remove the ICA together with the tumor. We perform it for young patients. In some cases you can use also a stent, but in some cases we have to perform this vascular bypass to remove together with the tumor. Some examples, that's a paraganglioma. You can see here this large tumor on the left side, this young patient, and after surgery, with complete removal of the lesion. Then next one is a schwannoma, large cystic schwannoma going down to the neck. You can see that's in the posterior fossa in the neck. Use the same procedure and remove completely the lesion. Meningiomas of the jugular foramen are rare, not so often. We are not including here those meningiomas from the posterior fossa or the petroclival region going to the jugular foramen. That are primary meningiomas of the jugular foramen. We have published years ago 12 cases, but we have now double. We have 24 patients. And you can see here one case. This case is interesting, where open the sinus was ligated, where open the sigmoid sinus. You can see the tumor inside of the sinus. That's the jugular bulb is here. That's the jugular vein. And then you open here the jugular bulb and also the jugular vein. You see the tumor inside of the jugular vein.
Professor Ramina, 1 minute more, please.
Okay, I'm finishing. You can see here the tumor inside of the jugular vein. And that's, we could remove completely. That's our results. We, in paragangliomas, we could remove for the 91 in 71 cases totally. And schwannomas are the best one to be removed. And we remove in 28 cases of 29. And we have some complications you can see here, and a mortality of 3 cases with pulmonary embolism. In one case, caudal cranial deficit after surgery, and a thrombosis of internal carotid artery were the cause of mortality. I'd like to thank you very much and many greetings from Curitiba. I hope you can sometime visit us here in South Brazil. Thank you very much.
Thank you, Dr. Ramina. I had a mistake in the presentation. Dr. Ramina is founder and director of Neurological Institute of Curitiba. Now we continue with Dr. Enrique Osorio Fonseca from Colombia. He is professor of neurosurgery in El Bosque University and president of the 70th WFNS Congress in Bogota. He's going to present microvascular decompression in trigeminal neuralgia, results and tips. Thank you, Dr. Enrique Osorio. It's a pleasure to having you with us.
Thank you very much. I want to thank Imad and Vladimir for your kind invitation to participate in this important symposium to honor our one of the most important pioneers of the modern neurosurgery, our Professor Majid Sami. I will talk about microvascular decompression in trigeminal neuralgia. Okay, this photo many years ago with three of my mentors, Professor Majid Sami, Professor Marc Sandou, and Yves Kerabel, and myself. And the first operations were performed in 1891 by Hartel and Krauss. They performed gangliectomy through subtemporal approach. And then in 1901, Spiller and Fraser made a neurotomy for the same way, retrograde neurotomy. And in 1930, Walter Dandy performed a suboccipital lateral cerebellous approach for neurotomy of the fifth nerve. And finally, in 1960, Gardner introduced the microvascular decompression, which was popularized by Janetta in 1966. There are very special sequences in MRI to be sure that there are a conflict with the nerve. And these are the special sequences, but the sensitivity and specificity with this sequence is more than 95%. And these are the sequences. Also, for some equipments, we can do the Fiesta and Drive. It's a 3D and T2 approach, but there are not. They cannot differentiate between the vein and the vein or artery to the nerves. Okay, the treatment for the trigeminal neuralgia, microvascular decompression, thermocoagulation with radiofrequency, ball compression, glycerol rhizotomy, and radiosurgery. But all the techniques different to the microvascular decompression are lesioning techniques. And the lesser postoperative hypoesthesia produce a higher risk of recurrence. And you see this important work, the literature review for more than 412 total publications. And you see the results a long time. The microvascular decompression is really the best. And then with the balloon, and finally with the other techniques. But no doubt that the microvascular decompression is the best solution for this problem. And the microvascular decompression has the same results a long time if you have a typical or atypical trigeminal neuralgia. And the anatomy, we can see that we have the sensory root in the inferior part of the nerve. And also it's important to know that the central, the myelin, central myelin is going through the nerve different to the other nerves into the brain. And for that reason, we have to look for the compression, the nerve, not only at the rest zone, but also in the peripheral places. And it's important to know the arteries and also the veins. The pontine vein is very important, this pontine trigeminal vein, to be to take in account. And we have to go to decompress all the veins are arteries. Many times you find veins, arteries, and multiple conflicts. And this is important. This is the technique I use. I learned from Mark Sandu, is only enter to the angle of the sinus, transverse and sigmoid sinus. And if it's possible, take out the arteries in conflict to the nerve for the best results. I use for many times this position, park bench position, but now I use this position is more fast for me and it's okay. And I can show you the compression with this cerebral superior artery. After I go with a ring of Teflon felt to go around the artery, the cerebral superior artery. Here you have the superior petrous vein. And with the ring, I go with the artery out to the nerve. This technique is very, very interesting because, and I can reinforce with another ring of the Teflon felt and take out the artery to the nerve. I reinforce, okay, and that's it. And this case, I have a patient of 50 years old and 5 years with constant hemifacial pain and burning in B2. And initially, we are going to liberate all the arachnoids around and see this vein is the pontine vein and is in close. I separate the vein, but in the superior part of the nerve, I am going to liberate the arachnoids, and we can see the superior cerebral vein. Sorry. And separate the artery also and put between the artery and in this case, I cannot to go with the ring to go out with the artery, but separate the artery with a small piece of Teflon felt. And now we are going to separate definitively the pontine vein to the nerve. And here we have another case. We perform the normal small craniotomy with the transverse and sigmoid sinus and open the dura around the sinus and go directly to open the arachnoid, liberate, and we have here the petrous vein and liberate completely the arachnoids. And we can see the pontotrigeminal vein now. We will see better now after the liberation of the vein. And here you can see the vein in contact with the rest of the nerve, of the 5 nerve. And I can dissect the vein and separate with the small piece of Teflon and close the as usual manner. Okay, this is the situation. And here we have another case, also a pontotrigeminal vein in contact with the nerve. I liberate completely the arachnoid and preserve always the superior petrosal vein. It is very important because more than 50% of the patients that you cut the superior petrosal vein have problems after. And I have, in this case, to open the petrous bone, the apex, to see perfectly the vein near to the cavum of Meckel, and to separate. Here you see the vein at the end, and I separate completely the vein and put between the vein and the nerve also a small piece of Teflon film. In this case, a Teflon Edwards. I put there a small piece of Teflon Edwards. This is the patient, and here we have a case with the basilar artery in conflict. Normally enter with the same incision. It's also left side, and liberate completely the superior petrosal vein. And here you see the I liberate the arachnoids, but the nerve completely with a compression and also deformation of the nerve for the artery. This is a grade 3 of Mark-Sandu classification of the compression, and liberate completely. And then you see the artery, the basilar artery, going down to the nerve. And then I put a small piece of Teflon Edwards in this case to liberate the nerve. And you see here the pre and with the dissection, and then with the Teflon. Okay, this is important if you have the possibility to free the without contact, to take out the artery, you have the possibility to have better results a long time, 84% in this case, in these cases of Mark-Sandu, and 68% with contact, with the, if you have contact with the prosthesis. And in my cases, I have 353 cases with a follow-up of 120 months. And the affected branches are B1, 5%, B1 and B2, 20%, B2, 43%, B2 and B3, 17%, and B3, 16%. And in these cases, the majority was the contact with the cerebral superior artery, and several inferior artery in 15% of the cases, and veins in 29% of the cases. 2% in the cases I cannot found a contact, arterial or vein contact. And the result for these cases are no pain, 81% of the patients, 10% less than 50% of pain, and recurrence in 9% of the patients. And the morbidity in these cases was facial hypoesthesia in 9 patients, facial transitory paresthesia in 5 patients, facial paralysis in 4 patients, the initial patients, hypoacusia in 5 patients, and CSF fistula 4 patients, wound infection 3 patients, chemical meningitis 1 patient, and deep vein thrombosis in 1 patient. No mortality. And the technical key points, I think, is that if you use dorsal decubitus or semilateral positions, you have less complications. Keyhole approach produce less CSF leaks and less retraction. Infratentorial and supracerebral route, you prevent the hearing loss in the is very nice, this approach to prevent this problem and other cranial neuropathies. And preservation of the superior petrosal veins is you have best venous return and less complication. And freeing route of the arachnoid adhesions from the breast to the Meckel cave, and look for more than 1 vessel. And make a traumatic dissection and produce less hypoesthesia and dysesthesia. And the prosthesis without strong contact with the root produce better long-term results, and use the topical nimodipine to prevent vasospasm. And the conclusion, final conclusion, is that the microvascular decompression in typical and atypical trigeminal neuralgia is the best election, with low morbidity and mortality. And some people say that the patient will until 70, until 75, until 80 years. Really, the most important is the good general conditions. I performed surgery in patients until 80 years with good results. And also the patient acceptance and the best results with the microvascular decompressions are in B1 and B2 trigeminal neuralgia. And finally, I want to say that the Majid Sami that we honor today, again, is really a master of masters. He's an extraordinary human being. He's a gentleman gift. He's a pioneer of the modern neurosurgery with a unique persistence and tenacity. For him, he fears the patients, and for that, he developed multiple minimal invasive techniques. He is an extraordinary teacher, showing and teaching all his knowledge without limits. He's a globetrotter of neurosurgery, organizer of workshops, courses, and congresses around the world. He's a political leader with a global vision and solidarity friend. Thank you very much, and I hope for you, all of you, presentially in Colombia next year, in Bogota, between March 13 to March 18 of next year. Thank you very much.
Thank you very much, Dr. Enrique Osorio. We have just 1 minute if somebody want to make a comment or for a question, please. Go ahead, Professor Keki.
Yeah, I thank you very much. It was a very nice paper. I enjoyed. I have a great interest in this subject myself, and I have done over 1,000 and odd cases of MBD. And I just want to reiterate that at no cost should you sacrifice the petrosal vein. It has a very common habit among some people because the petrosal vein comes in the view of your operation. And I have seen even good surgeons trying to coagulate this and cutting it off. But it is not a very good idea. And someday you can have very bad cerebellar swelling and a mortality, which is not acceptable in patients with this benign disease. That's one point. The second point, which you also showed very well, was the drilling of the suprameatal tubercle. Occasionally, the CP angle or that area is so narrow, the petrotentorial corridor in which you're operating is very narrow, and the petrous bone bulges into it. And quite often, there is a vein which is hiding underneath and compressing the trigeminal nerve, not near the root and zone, but more laterally. And you do require to drill, as you showed very nicely, that you need to drill the suprameatal tubercle in order to get space and see the vessels which are far away from the root and zone. Sometimes you may, and as you also mentioned, it may not be one vessel, it can be more than one vessel. It may not be just an artery, it can be artery and vein. And in one patient, I have had 4 vessels intimately connected to trigeminal. May be not, they are all of them are causing neuralgia, but it's always better to decompress all the neurovascular conflict wherever you see it, whether arteries or veins, and small or large or medial or lateral, everything must be decompressed. And one last quick point is what happens when you don't find a vessel. That's an important point. It has happened once in a while when you are doing a lot of cases, and therefore I always talk to my patients that of course MRI is very good, almost 90% useful, and pain is quite typical, and therefore you need to operate on them. But once in a while you may not find a vessel, and then you take a consent for doing a partial sensory rhizotomy, which may produce a little bit of numbness. So that kind of a consent is to be obtained. But usually you would always find a structure, always find, and quite often it is a vein which you are missing. And an endoscope can be quite useful in such corners where a microscope cannot reach. So you need an endoscope to see 360 degrees around the nerve. So
Thanks.
These are my few comments. Thank you very much.
Thanks, Dr. Keki. We continue with Dr. Giovanni Broghi from Italy. He is professor and chairman emeritus of a Neurological Institute in Milano. He is also scientific director of the Fund IEN in Milano, Italy. He is going to present us spinal tumors surgery. Tips and tricks. Thank you, Dr. Giovanni. Go ahead, please.
Good afternoon or good morning for everybody. I'm very happy. Sorry. Okay. This is the end. I'm very happy to be invited again from Imad and Vladimir to present a kind of webinar in honor of Majid Sami. So surgery of pineal tumor, and I have nothing to disclose, if not to make honor to Majid. That is a master for all of us, and every time that I visit him, I learn something of his surgery. Pineal region tumors. What is the pineal gland in the different culture? That is quite important, quite interesting. From the Babylonians time till the more recent time, the pineal gland was individuated as the third eye. This is quite important. This is a drawing from Egyptian time, and you see here that it's quite similar of the anatomy that you can find around. And for many other culture, the third eye was very important.
Can we
from
get
the
that creature quiet, or close the phone or the microphone, whoever has that dog?
Yeah, that's I take out the dog. I'm sorry. Sorry.
It's your handmade.
My assistant is my assistant.
Okay.
But it's quite uneducated. So the Maya and the Sicilian have the third eyes. But what is you can find out with the history of René Descartes, that was thinking that the soul was here till the Christian Pope that is using the same type of the shape of the pineal gland in this, and that is true also for the Buddhist religion and philosophy. And what is most important, if you go to the nature, the iguana has a third eye that is tied up with the pineal region. I do not see its function as a eye, but anyway, there was a structure. That means that in the past, pineal region was really very important and is still very important for other things. For instance, for the circadian rhythm, because it's tied up with the secretion of hormones and the night and day or dark and light. After this brief history of the pineal gland, let's go for what is the topics, the tumors. There is two big review of the management of pineal region. One is from Stein in 95, and the other one from the Burdengo group. That's quite large, and I think that is very important because it's are showing the different type of tumors and lesion that you can find out in this region. The Besta Institute is no different for the other one. You see here the germ cell, the gliomas, and the pineal tumor is more or less to 30%, and after you have a mix of other more rare type of pathology. How to reach the pineal region? There is two ways. One is the transtensorial interhemispheric, and the other one is supracerebellar subtentorial. Let's see the second one. Is not what I'm using usually, and this is the picture that Charlie Teo gave to me. And you see here that in this situation, the anatomy that you can find, the most important things are the vein, and that is the most, let's say, difficult type of limits of danger of this approach. That is very, very good for the big lesion. And that's what the publication that he did. Tips and tricks. So let's go for the semi-sitting position on supracerebellar approach. That is what I would like to show you today. Sitting, semi-sitting, as Majid was always proposing. Very important is the examination of the patient before to choose the position and to take care of some difficulties, cardiological difficulties that you find. Wide craniotomy in posterior fossa, microscope and or endoscope. I will show you that you can use both, and it's very important for some type of pathology. Monitoring is important as every region of the brain, but in this situation it's much more important because the anesthesiology can change and modify his behavior. One of the most important things, as in many other approach for the lesion, is the sharp dissection. Osorio, Enrique was showing now for the trigeminal neuralgia. In the previous lecture, everyone was using sharp dissection. Don't stretch, don't cut without seeing what we are doing. And the other things that is tied up with the positioning is the team, the astrological team has to be very trained and in good shape with you. Supracerebellar intertentorial. And let's show a few cases. Pinealoma. You see here one case very fast, not to take out too much. This was the lesion at MRI. You see here MRI in the sagittal situation to show the different situations. That is what you find when you open in supracerebellar. You can cut the bridging vein, You have the lesion here. You have to cut all the arachnoid around, little by little, till you find out your lesion, and of course, as usual, you can take out. And that's what you find out later on. You open the third ventricle. This is the posterior commissure, and that is a beautiful anatomy. I don't want to go around to make a tour, and this is the commissure, and that is the post-op of this particular case. Meningioma, that is quite rare, but you can find there the strategy is almost the same. Of course, when you have a huge meningioma, maybe the supratentorial approach can be used. Of course, you can use the ICG to see the vessel, and again, sharp dissection to clean up the lesion. Neonavigation is very important. Ultrasound aspiration is also important with low power, because it's very delicate, and the ultrasound aspirator can be very dangerous in this region. You can check again the patency of the vein and the arteries that are around step by step till you find out what is the post-op, and you see here the situation that's around. Epidermoid, that is quite important, because we can discuss what is the meaning of the endoscope. You see here the pre-op MRI, a huge lesion that is going up till the lateral ventricles. Usual approach, and piece by piece the epidermoid can be removed. In this case, the vein was keeping patent because of the circulation that was studied before with the Andrea MRI. Let's go ahead, because that is something that is nice to see, but not so useful discussion. And when you have almost at the end of the removal, taking out also the capsule, that is very important to reduce the percentage of recurrence, you can use the endoscope just to check what, and you see that the roof is still full of lesion. And that's from this situation, you cannot remove it. And you have to think, as you will see here in the next, in the post-op MRI, you see here that this is completely clean, but here you have the lesion. And I think that you have to get, for this particular patient, another approach. That was the young lady afterward. Sometimes you get pilocytic astrocytoma, and the fluorescein can help you to find out the lesion that is innervated in the nearby the pineal gland and in the mesencephalon. And that was the post-op. This again, this approach can be done only with endoscope, yes. Of course, you have to be trained on that. That was, again, another epidermoid cyst. And you see here that the corridor is huge enough to allow you to move the endoscope or to fix the endoscope and have to hand. The endoscope can be fixed with the holder, or you can have an assistant that is working as an holder. And the corridor is quite wide, because for gravity, the cerebellum is going down. So again, sharp dissection, sharp dissection, sharp dissection. And again, And that's the pre-op and post-op. So we are talking about tips and tricks. Supracerebellar approach, if you choose this one, the sitting position, in my opinion, is mandatory, sitting or semi-sitting. If you are working in so-called concorde position or prone position, the gravity is not helping you. And you have to make a retraction of the cerebellum, so you lose the advantage of this huge corridor that gravity is giving to you. This is semi-sitting position, this is the incision, and of course it's very important to know the position of the patient, the relation of the tentorium to the floor. The best way is to have almost horizontal. That is is almost impossible, but you have to know what will be your corridor, and you have to tilt the table in such a way that you can work with the possibility. Of course, sitting position has a pro and con. There is a complication, gas embolism, the rectal paradox, the hyperperfusion, the pneumocephaly is always present. The tetraplegia is very important that you put the patient in semi-sitting position without curarization. Otherwise, the danger of the wrong positioning can make a lesion of the cerebral or the cervical core. And the compression of the peripheral nerve is the same. That you have to be sure that the arms are positioned in a good way. There is a debate if this is obsolete or not. This editorial of the British Journal of Anesthesia in 2002 is point out a very good point. Should limited use of sitting position remain the surgeon armamentarium? The answer is yes. And to all of us that we learned from Majid know what is the advantage of the data, and now our duty is to train our anesthesiologists to do that. Advantage of the sitting position. The gravity, I already show you, the cerebellum is going down. You have drainage of blood, so of the CFS and all the irrigation that you do without problem. There is a wide corridor. There is no retraction of the cerebellum, and the bleeding is, and the peak is definitely reduced. This is the experience of the best institute that we had. You see here that the number of cases done per year from pineal region, that is the topics of today's, spinal, cervical spine tumor, occipital cervical decompression for cardio, other things. That is almost 170 or 180 cases per year. Of course, you have complication. You cannot, as the French people say, you cannot make an omelette without breaking the eggs. In 40% of the cases, we have air in the atrium, so it's very important that the anesthesiologist be aware of that and take out the air. Very low, no risk of embolism and permanent lung damage. The pseudocephalus is 100%, but no responsible for deficit, no problem with the larynx edema, and of course, no tetraplegia. But that is something that we have to be aware that can be happen if you have a patient corization. What to do about the pneumocephalus? It's possible to have also in the prone position. This was from epilepsy surgery, you see here, and that's from a large aneurysm surgery operated before, and you get the same problem because air is getting inside when you take out the CSF. The therapy of pseudocephalus, as we already discussed in another webinar, is to be patient. Patient, and the surgery and the surgeons should be patient. Patients should be intubated, stay intubated for at least 1 day or hours, take the CT as a control, and wait and wait and wait, and after you can come out. Of course, it's not only us and Majid people. Majid is himself and all his pupils that are using semi-sitting. You see here a very good paper from Ernest Niemi about his experience. Other tricks, monitoring, evoked potential, BIS, the control of EEG during the anesthesiology, transthoracic Doppler to avoid the paradox embolism, and of course the central catheter with the Benegin-Albing way to take out the air when it's going out into the hair. To conclude, the advantage and the way to approach the lesion in the pineal region, supracerebellar approach is very, very convenient because of the gravity is making you the corridor of working, and there is less bleeding than in the other situation. But also there is some other problem. It's very tiring for the surgeon. You need a trained anesthesiologist. And my friend Spetz refused to do that because he said it was tiring with the head for hours there. But there is the chair and there is the way to rest the arm when you are working. Of course, you need, as in all approach, a good surgical training, and the selection of the patient is very, very important, not only for the anesthesiological point of view, but also, as I show you, because of the shape of the posterior fossa. You have to know what is the inclination of the tentorium, and of course, the monitoring. So this is my team on which I worked for many years, and it's working again, and they are very good and better than me. And at the end, with a little tap, happy birthday. Thank you.
Thank you, Dr. Giovanni. Very nice lecture. So, Dr. Ayman, Dr. Vlad, go ahead, please.
Yeah, well, thank you very much, Victor, for moderating this session, staying late. I'd like to thank all the speakers that they have the time and the effort to produce special academic sessions in recognition and honor of our legendary Professor Majid Sami from all the 6 continents. There are a few of them left behind, and see some of them, they have already midnight, they left. I hope tomorrow will be another active day. There were a lot of questions on the question that need to be answered. Please check whatever related to your topics to answer them. There's a young neurosurgeon from around the world watching you and like to inhale from your experience. Thanks for everybody, and I hope you have another successful day tomorrow. Best to you and your family. Stay safe and be careful with the COVID, even with the vaccination. Take care and have a good night. Ciao. Bye-bye.
Ciao to everybody.
Thank you.
Bye-bye.
Thank you very much.
Bye-bye.
Good luck.
Before we leave, can we take one picture with the group, please? Group pictures with the cheering and smiling and
yeah. Thank you.
Thank you. Take care.
Hi, Armando.
Armando.
Hello. Hello.
Armando is there. Evergreen. Hi.
I see Lucas. Lucas are here now on the screen.
Yes, I would like to. Hi. I would like to congratulate to Imad and to Vlad and to all of you for this outstanding webinar. I enjoyed very much following this presentation. Just for the photo. Today.
Okay, gentlemen.
Ramesh, Ramesh, you are not showing. Ramesh in the car. Oh, I see.
Ramesh is in the car. Yeah.
Now he is driving fast. Okay. Take care. Have a good night.
Bye-bye.
Bye.
Bye.
Bye. Bye-bye.